I welcome our branch president, Dr. N. Subramaniam sir, for giving his welcome address.
Thank you. Good evening, everyone. So it's really a warm welcome to all our delegates from the state and our state president, Dr. Abdul sir, AMS chairman, Dr. Rajesh Babu sir, and secretary, Dr. Jayaraman sir, and also our NHP state chairman, Dr. Anubarajan sir, and zonal vice president, and also all the speakers and chairpersons, presidents, secretaries of all the branches down from Madurai to Kanyakumari. So it's really a program processed also with the Medical Council approved CME. So we request all of you to share your expertise on the different field. So we have a slightly different program, like you have a moderator and also expert intervention. So each specialty we have expert who also can chip in with their special comments. And we also have our AMS branch chairman, Dr. Panneerselvam sir, who is also a psychiatrist and also very much passionate about AMS. He is going to talk to us about mental health issues. And we have opening batswoman, Dr. Geetha Krishnan, and chaired by Dr. Abdul Aziz sir from Kutralam branch. So I sincerely thank the state office for IT support and also our branch members, especially Dr. Prabhuraj and all senior members for supporting this initiative to host the South Zone IMA AMS CME as a virtual one from Tirunelveli IMA. Once again, warm welcome and wish all this program all the best. Thank you.
Thank you, sir. Thank you for your wonderful speech, sir. Thank you. May I welcome our state president, Dr. Abul Hassan sir, for his valuable speech, sir.
Thank you, Dr. Prabhupada. Good afternoon to all of you. My dear friends, Rajesh, Subramaniam, Dr. Abdul Aziz, Dr. Jayaraman, and all my dear friends. It is indeed a very wonderful idea to have a South Zone AMS conference on Zoom involving many of the South Zone branches of Tamil Nadu State IMA. And I also saw the topics which was very, very timely and also very informative. For example, you have added information about monkeypox and also organ donation. Everything is there. Though I always believe that more number of Zoom meetings probably reduce physical meetings and socializations among doctors. I think once in a while we should have a meeting of physically presenting everybody in the South Zone. Probably before the conference, you can kind of Tirunelveli can organize a meeting of South Zone branches where people are present physically and have a very nice socialization also. However, this kind of program definitely update our knowledge of the current situation in the medical profession. I thank Tirunelveli IMA, Officer Subramaniam, Ibrahim and Prabhuraj for organizing and bringing lots of speakers with wonderful topics and also members to the meeting. I wish the program all success. I am very happy to inaugurate this webinar. Thank you very much. Over to you, Dr. Prabhuraj.
Thank you, sir. Thank you for your words of wisdom, sir. May I request Dr. Rajesh Babu sir to have his few words, sir.
Good afternoon, everybody. First of all, I thank our President, Dr. Abul Hassan sir, for giving the permission to conduct the South Zone IMA AMS TNSB zonal conference. I welcome you all. First of all, I thank the President of Tirunelveli, Dr. Subramanian, who is immediately after telling to conduct the program, immediately they obliged and started working on, and the Secretary Muhammad Ibrahim also actively participated, and they created nice galaxy of speakers, and because each and everything is from different places. It is very nice to see like that. And at this juncture, I like to thank Dr. Anburajan sir, the NHB chairman, who is from Tirunelveli area, and the vice president, Dr. Kaliur Rahman. Thank the Tirunelveli branch for only taking this opportunity and conducting the South Zone Conference. Thank you, one and all.
Thank you, sir. Thank you for your kind.
Request Dr. Jayaraman sir to give his speech, sir.
Thank you, President Subramani sir. First of all, thank you all the Tirunelveli IMA branch. It's a vibrant branch. So Oxford of South Tirunelveli, we call it as. So respected President and respected Chairman Rajesh Babu sir, and all the leaders of our Indian Medical Association. So very proud to have this kind of a program from IMA AMS. That is the IMA AMS South Zone online conference. Thank you, Tirunelveli team. So congratulations. Already our chairman mentioned very clearly about that. I request all the members, those who are having the postgraduate qualifications, kindly enroll in the IMA AMS Academy of Medical Specialties as a life member. Just you pay 1,180 rupees, either check or DD or online transfer. Just one page form only, fill the details and send to the our Honorary State Secretary Karthik Prabhu sir, become a life member in the IMA AMS. We do a lot of activities. We have IMA AMS fellowship course, certificate courses, 6 months and 1 year online offline courses for our own members. Kindly utilize this opportunity. The Timon newsletter, everything is there. Kindly go through and update yourself. Thank you very much for the opportunity. So congratulations, the best wishes, sir. Thank you, sir.
Anburajan sir, for his few words, please. Good evening, sir.
Good evening to all. It's a great thing that AMS in Tamil Nadu is coming with a lot of innovations and a lot of training to our doctors. Especially as it was told by Dr. Abdul Azizar, the Tirunelveli branch is having is a very vibrant branch now, having doctors in all the specialties, and they are involving in various aspects in their specialty. Especially Dr. Panisulum, who is here, he is being the president of their Psychiatry Society, and he is doing a lot. So now training has become, and foundation of our knowledge is also become very important, that everybody should have updation in their aspect. And that's why the IMA, whole IMA, either whether it is a central IMA or the state IMA, always instigating their bodies to conduct a lot of series of lectures and CME programs through all its wings and all its branches. So AMS, especially, they are coming up with very practical, issues and very practical knowledge patient with highly qualified people in the concerned field. So the topics who are selected are also very important for the practitioners, that they have to get updated in their knowledge. So I wish all the best to AMS Tamil Nadu and also the Tirunelveli branch for conducting this CME program, and definitely this will be of much useful for all the participants who are hearing the lectures today.
Thank you, sir. You have always been a big encouragement and supporter for our branch, sir. Your guidance will be helpful, sir. Thank you, sir. May I request our AMS Secretary, Dr. Paniselvan, sir, for his few words, please.
Respected President of the Tamil Nadu IMA and President of the AMS Tamil Nadu branch, and our Tirunelveli IMA President Dr. Subramanian, and all the office bearer of state branch and the AMS branch, very good evening to all of you. Thank you for providing Tirunelveli IMA. We have a very topic for presentations, and it covers many branches of Southern District, and also all the speakers, the eminent speaker. I hope this webinar will be useful, and it's also stimulating, brain stimulating. Thank you very much, our President, Dr. Subramanian, and thank you all. We start the program. Thank you because we inform the time for I think another 5 minutes. I think. Thank you, Dr. So
thank you, sir. Thank you, sir. Thank you, sir.
And it's just 4 o'clock. I think we'll be ready to start.
Yes, sir. We can go ahead with the scientific session.
Over to Prabhu, sir. Yes.
We can go ahead with the scientific session, sir.
Okay.
May I request Dr. Geetha, madam, to share her screen?
Thank you, sir. I'm Dr. K. Geetha, consultant pediatrician. I'm presently working as Chief Civil Surgeon Pediatrics in Tenkasi Headquarters Hospital. And I'm also the District Early Intervention Nodal Officer of Tenkasi, sir. My topic, vaccination guidelines, is a very vast topic. And each vaccine itself takes a lot of time, but I have tried my level best to bring it into a very small, concise topic. Though this topic is a vast subject with a lot of ifs, don'ts, unclear guidelines, and availability of several vaccines in the private market, I would try to clear and summarize all the vaccines as possible. Now, coming to the vaccination guidelines, generally, all the doctors know about vaccination in children up to 10 years, vaccination during pregnancy, vaccination during injury, vaccination after dog bite. Is there something else? Actually, vaccination beyond childhood through adolescent and adulthood and old age is an important area which cannot be neglected. 25% of deaths in adults is due to vaccine-preventable diseases in comorbid conditions. Now, we cannot leave the government immunization schedule. Actually, since I'm basically a pediatrician and all pediatricians know about vaccination, I'm just giving you a small gist of it. The first one is at birth, within 24 hours, you're supposed to give hepatitis B vaccination. And BCG and oral polio vaccine is given within discharge of the baby. And then at 6 weeks of age, we give pentavalent vaccine, which comprises of diphtheria, pertussis, tetanus, hepatitis B, and HEP vaccine together as a single shot, which is called Pentavac. And we give rotavirus vaccine, we give pneumococcal vaccine, we give oral polio vaccine, and also the injectable polio vaccine on 6th week of age. At the 10th week of age, we give the Pentavac second dose, and then we also give the rotavirus second dose with oral polio vaccine. In the 14th week of age, we give Pentavac vaccine, we give once again the rotavirus vaccine, the injectable polio vaccine, and the pneumococcal vaccine, and the oral polio vaccine. Then the vaccine comes at 9th month of age in government settings, where we give the MR vaccine, which is the which is the measles and rubella vaccine. And along with this, we also give the PCV shot third dose, as well as injectable polio vaccine third dose with one first dose of vitamin A solution. This vitamin A solution is given as 9 doses over a period of 5 years with a gap of 6 months. The next shot after 1 year is from 15 months to 18 months. And there we give the MR second dose, which comprises only of measles and rubella as a subcutaneous dose, and DPT first booster dose with polio drops. Then we have a vaccine at 4 to 6 years of age, which is a DPT booster second dose along with oral polio vaccine. Then a vaccine is given at 10 years of age, which is the TD vaccine, and 15 years of age, which is another TD vaccine. These are all the normal vaccines which are given. Now, let me also tell you about the IAP vaccination schedule, because that contains more vaccines compared to the government vaccine. Though the government vaccines are the most important vaccines which everyone has to get, we also need to know about certain vaccines which do not come under the purview of government vaccines. And that is I'll tell in, I'm not going into the detail of the regular vaccines, which we already know, but at the end of 6 months, we have the influenza vaccine for the baby, and that is first shot is given at 6 months of age, and with a gap of 1 month, we give the second influenza dose. And from 6 to 9 months, we give a typhoid conjugate vaccine to the kid. And another recommended dose is hepatitis A vaccine at 1 year. Instead of MR in government setting, we give an MMR, which is measles, mumps, and rubella after 9 months of age in private settings. This mumps is very important nowadays, and I hope everyone must have seen cases of mumps, and that is not being supplied by the government vaccine. Now, at the end of 12 months, we have the hepatitis A vaccine. It's a single dose if it's given as a live attenuated vaccine, and it becomes a 2 dose with a gap of 6 months in between if it is a killed vaccine. Then at 15th month, we give the second dose of MMR. Along with this, we also give varicella zoster vaccine and PCV booster first. 16 to 18 months, we give DPT pentavalent along with IPV vaccine. At the varicella second dose as well as the hepatitis A second dose is given at 18 months of age. And then all vaccines are the same as that of government, except for an MMR third dose at the end of 6 years. Here, a special mention to meningococcal vaccine, Japanese encephalitis vaccine. The Japanese encephalitis vaccine is given to kids when it is an endemic area. Otherwise, it is not recommended. So this is about childhood vaccination, and everyone will be knowing about it. Now, the next vaccine, which is always common to everyone, is vaccination during pregnancy. And as we all know, if it's the first pregnancy, you're supposed to give the first dose of TD or Tdap as soon as you register a case of pregnancy. And the second dose will be given 4 to 8 weeks apart from the first dose. And if the woman becomes pregnant within a span of 3 years, the 1 dose of TD, a booster is enough, and that can be given from 28 weeks to 32 weeks of conception. So that's all about pregnancy. And now coming on to vaccination after injury, we all know now TT vaccine is not used as there are incidences of diphtheria as well as pertussis in many places. And so the most advocated vaccine is T and D, TD and Tdap, which is mild dose of diphtheria added to tetanus, and mild dose of diphtheria as well as pertussis added to tetanus. And if the person is a regular vaccinated person, a gap of 10 years is allowed for the another dose of Tdap. If the injury is going to be a very pierceful injury, which is very deep, you can always advocate a vaccine if it is only less than 5 years. Now, coming on to vaccination after dog bite, all of us are well aware of category 1, 2, and 3 dog bites. When it's a category 1, there's no need of an anti-rabies vaccine. If it's a case of category 2, anti-rabies vaccine alone is enough. And in a case of category 3, where there is lacerated injury, we have to give anti-rabies vaccine along with rabies immunoglobulin. If it's an intramuscular vaccine, as which is given on the private sector, it's a 0.5 ml dose intramuscular on the deltoid at 0 dose, 3rd dose, 7th day, 14th day, and 28th day. If it's an intradermal injection, which is given on each deltoid 0.1 ml, then it has to be 4 doses, the 0 dose, then on the 3rd day, 7th day, and 28th day alone. So this is all about some vaccines up to 9 years of age. Now let me come to the adolescent vaccine. So the recently talked about much hyped vaccine, which even our finance minister has been telling on the budget, is our human papillomavirus vaccine. And this is a much needed vaccine as of now. There are a lot of cervical cancers. That stands the second most important cancer after breast cancer in females. And if this can be prevented, that's a big, big success. So for this, it has to be administered before as actual sexually active life. So girls are recommended a vaccination from 9 years up to 26 years. But if it is below 15 years of age, 2 doses alone is enough. And that is a 0 dose and a second dose 6 months later. And if the girl child is more than 14 years, from 15 to 26 years, HPV4 can be given as 3-dose regimen, 0 dose, second dose within a month, and the 3rd dose after 6 months. Even for boys, HPV9, HPV9 is advocated, and that is from 9 to 21 years. And that's a 2-dose HPV vaccine. Now let us come to the adult vaccine. The adult vaccination, when you see this table, it appears very, very difficult to understand and appears a bit complicated, but I can make it a very bit smaller for this is the real vaccination schedule as of now. But let me come into the minor details of it. Now, first one, we'll talk about the influenza vaccine. In adults, influenza vaccine, there are 3 types: live, inactivated, and recombinant. This live attenuated vaccination can be given annually for any person from 19 to 49 years of age and even after. And this inactivated and recombinant vaccine can be given annually depending upon the strain. Now, on special situations where there is an immunocompromised state, we give only inactivated and recombinant vaccine, and that is when the person is suffering from anatomical or functional asplenia, CSF leak, cochlear implant or something, where live vaccine is not advocated. Now, coming on to pneumococcal vaccine. This is another important vaccine, which is very, very important for adults. Any person, there are 2 types: pneumococcal conjugate vaccine, PCV13, and pneumococcal polysaccharide vaccine, PPSV 23. Let me tell you, any adult more than 65 years, you have to routinely vaccinate with 1 dose of PCV13 followed by a 1 dose of polysaccharide PPSV vaccine after 1 year. In special situations like chronic heart disease, lung disease, liver disease, dialysis, 1 dose of PPSV 23 is advocated. And in immunocompromised persons, hematological conditions, nephrotic syndrome, on steroids, malignancy, cochlear implant, and CSF leak, we advocate 1 dose of PCV13 followed by 1 dose of PPSV 23 after 8 weeks. Now, coming on to another vaccine which everyone knows, hepatitis B vaccine, we all give to adults also when they go for medical schools, for labs, etc. So this is also advocated for any adult at risk, like who is sexually active, who's got a percutaneous or mucosal risk of exposure to blood and blood products, dialysis patients, incarcerated patients. The dose here is intramuscular and it is given as 3 doses: 0 dose, a second dose 1 month later, and the third dose another 1 month later. These are the important vaccines which I felt that I should tell in detail. Now, since the time is very less, I'm talking about the vaccines on special indication: hepatitis A, meningococcal vaccine, H influenza type B vaccine, cholera vaccine, MMR vaccine, varicella, zoster, and COVID vaccine. When you come to this meningococcal vaccine, cholera vaccine, varicella, H influenza B vaccine, etc., these are all specialized vaccines which are indicated or given only in special conditions where there is a large outbreak of meningococcemia, where there is a large outbreak of cholera, etc. So for travelers, cholera vaccine is advocated. Then when you come to hepatitis A, that is given to people who are at risk. And this varicella zoster, varicella vaccine can be given to anyone after 19 years if they are immunocompromised. This zoster vaccine is given, actually advocated for anyone below after 50 years because they are prone for, they would have contracted chickenpox at their younger age and they are prone for their HEP B zoster and should not suffer from that. So zoster vaccine is available and that can be given after 50 years. I don't want to go about the COVID vaccine that has got a lot of problems as of now. So we all have to be proud at least that we were indigenously India produced COVID vaccine for COVID for us. So we should be thankful to the government for that. Now, now the vaccines on trial. So now the vaccines on trial are dengue vaccine, HIV vaccine, malaria vaccine, respiratory syncytial virus vaccine, hepatitis C vaccine, and Ebola virus vaccine. They are on vogue. Let me give a special mention about the immunoglobulins available are tetanus immunoglobulin, hepatitis A immunoglobulin, hepatitis B immunoglobulin, rabies immunoglobulin, varicella immunoglobulin, and as we all know, there's an IVIG for many common diseases. So I think I have given justice to all the vaccines. To summarize, the UPI or the Universal Program of Immunization should be given to all children below 15 years. TD Tdap for all pregnant women. Hepatitis B vaccination within 24 hours of birth. TD Tdap only after 7 years, not below that. the pneumococcal vaccine and influenza vaccine to be initiated for adult population as and when needed. Human papilloma virus vaccine to all girls to be initiated. Thank you very much, sir.
Thank you, madam. Thank you for your wonderful speech. You have almost covered everything in a short span of time. May I request Dr. Abdul Aziz sir for his expert opinion, sir?
She has 100% excellent and exemplary. Actually, when we discussed in the morning, we discussed that she has covered completely in a perfect manner. Actually, the credit goes to Dr. Subramaniam, who was very instrumental that IMA Kuttalam should take part. So our president asked me, but I told I am very busy with the state council meeting. When I asked Dr. Geetha, she accepted and she has produced a wonderful speak as a opening spokesman. She has done well and well in time. So time is 4:15. Let us, on behalf of Kuttalam IMA, our president also cooperated. We thank all the Tirunelveli office bearers. Thank you very much, sir. Thank you.
Thank you, sir.
Any questions? Any questions from anybody in the group? We can take 1 or 2 questions.
Regarding one point,
I have one question, madam.
Yeah.
Yes, sir.
If nowadays when there is a college admission, they are insisting on hepatitis B vaccination.
Yes,
so
sir.
do we check the antibodies before we do the vaccine, which is a booster anyway?
Sir, actually, hepatitis B vaccine can be given every 10 years. The vaccine's immunogenicity wanes within 10 years. That's what they say. So even if the child has been vaccinated as a regular vaccine has been given up to 1.5 years of age, it is not wrong to vaccinate the child at given hepatitis B shot after when they go to the medical school. That will be good for them. It will say protection. In fact, you cannot say 100% protection. That's what CMC Vellore immunologist was very particular. He says it's not 100% immunogenicity. So it is better to give a vaccine. And in our setting, finding out antibodies is going to be very difficult. Rather than that, to give a vaccine will be better, sir.
Okay. Thank you.
We'll move on to the next session. That is a practice update on type 2 diabetes by Dr. Kumaravel, sir. May I request Dr. Bharat, sir, to introduce him?
So, good evening, everyone. So, it's a pleasure to introduce Dr. Kumaravel, who did his MBBS and MD General Medicine in Madurai Medical College and DNB Endocrine in Amita Institute of Medical Science, Cochin. And so, he's a consultant and endocrinologist in Alpha Hospital and Research Center, Madurai at present. He was awarded Honorable Professor IMA GCP in New Delhi. He's a course director in FCE organized by IMA CGP. He's a president IMA Madurai, actively involved in basic science and genetics research. He published in national and international journals a lot of papers, has contributed in revised IAP growth chart. Thank you.
Thank you, sir. Over to Dr. Kumaravel, sir.
Respected sir, hope I'm audible now.
Yes, sir.
Thank you, AMS, and thank you, respected faculties, for this great opportunity. It's always been a pleasure to be among you. The topic for today's discussion is going to be practice updates in type 2 diabetes. I think the first update which I would like to give is, it has long been there. Type 2 diabetes is spelled as type 2 diabetes. It is not the Roman letter, is never used nowadays. So it's either type 2 diabetes or type 1 diabetes. So the first common problem is that how do you diagnose diabetes? I think there have been lots of confusion in the basic diagnostic criteria of diabetes also. So as a general practitioner, we see, I'll give you a common case scenario. A 42-year-old male detected to have a random blood sugar of 232 during a routine screening. So does he have diabetes or not? So basically what we do is any blood sugar more than 200, we brand them as diabetes. Now, what exactly do the guidelines say? So this patient is asymptomatic, just a routine screening of 232, whether to call him diabetes or not. So the criteria for diagnosis of diabetes is very, very clear. One, your hemoglobin A1C, which is more than 6.5, or your fasting glucose, which is more than 126, where you define fasting as no calorie intake or fasting for at least 8 hours. Or when you go oral glucose tolerance test with 75 gram anhydrous glucose dissolved in water, and when it is more than 200, you call them diabetic. So when none of these criteria is available, when you do a random blood sugar for whatsoever may be the reason, and if the random blood sugar is more than 200, unless the patient is symptomatic, you need not call them as diabetes. So this has to be checked once again. So in an individual with classic symptoms of hyperglycemia, which could be polydipsia, polyphilia, or patients with hyperglycemic crisis with random blood sugar more than 200, you can call them diabetes. Our patient has no symptom as a routine screening, so we need not brand him as diabetic patient. So diagnosis is very, very important for most of our patients. So the criteria, which again clearly mentions HbA1c as one of the diagnostic criteria for diabetes. The reason why we use HbA1c as the diagnostic criteria is that it can be done any part of time. Fasting is not required. And what exactly is this hemoglobin A1c, which is nothing but a measure of erythrocyte or RBC hemoglobin glycation. Since RBC's lifespan is around 120 days, we say this HbA1c reflects your previous 3 months blood glucose. And HbA1c is the most useful single index of blood glucose control which is available. So for long it has been used in monitoring of diabetes. Now we have started using HbA1c as a diagnostic tool also. And it is one of the most closely linked parameter for the long-term microvascular diabetes complications. Now, again, we have lots of general practitioners here. We should understand hemoglobin A1c is something different from glycosylated hemoglobin or just hemoglobin H or hemoglobin A1. For example, glycosylated hemoglobin is unglycated hemoglobin, which is unmodified hemoglobin. And glycosylated hemoglobin includes hemoglobin of all parameters, hemoglobin A, B, C, and in A1, A1B, A1C. In diabetes, what we are specifically looking at hemoglobin A1c. So routine labs which report glycated hemoglobin or glycosylated hemoglobin or hemoglobin A1 may not be the gold standard HbA1c what we are looking at it. So what do the guidelines say? How exactly it has to be done? The A1c test should be performed using a method that is certified by the NGSP program. Second, we have now lots of point of care, what you call POC A1 testing. So where you have a card-like thing, you test a hemoglobin A1c. So many of these point of care A1c testing may not be useful for a diagnostic because they may not be very much standardized. Third thing, you could have a condition where your HbA1c could be falsely high or low, like patients with hemoglobin variants, patients who are pregnant, patients with glucose 6-phosphatase deficiency, HIV patient, hemodialysis, patients on blood transfusion, erythropoietin. In such patients, you cannot rely on hemoglobin A1c and you should bank them on plasma glucose criteria. So once when you diagnose a patient with diabetes, your treatment guidelines or the treatment targets would be your A1c should be less than 7. And I think now EASD, today morning, there was important paper which was submitted, which says your HbA1c target should be less than 6.5. And again, these numbers would keep on changing. It should be 6.5, 7, 7.5. But you fix up a target, fix up a guideline, and try to achieve those things. Your preprandial capillary plasma glucose should be between 80 to 130, and your peak postprandial should be less than 180. So you can see the guidelines very clearly suggests the peak postprandial. Your peak postprandial in Western would be 2 hours. In Indian setting, when you take more of carbohydrate diet, your peak postprandial happens at 1.5 hours. So your postprandial blood glucose can be done either at 1.5 hours or either at 2 hours, but whatever you follow, fix it up. I would suggest in Indian setting, your peak postprandial would be 1.5 hours. So to go with 1.5 hours postprandial. Western standards, because of the dietary pattern, your peak postprandial could follow at 2 hours. So you can go with 2 hours. But either of these things may not have a major difference, but you stick to one thing for your postprandial glucose. Apart from your A1c goal, apart from your fasting and the postprandial blood glucose, another thing we tell most of the patient, you monitor your blood glucose periodically. So you have a glucometer blood glucose, what you call it as SMBG or self-monitoring of blood glucose. This is what we have been doing for decades for most of our patients, either of your venous plasma glucose or your glucometer glucose or A1c. But now what we understand is your journey has moved beyond SMBG to a continuous glucose monitoring. So the difference between continuous glucose monitoring and SMBG is that your blood sugar, SMBG is done whenever you want to check the blood sugar. So if suppose you can see this patient, I have done a self-monitored blood glucose, you have everything falls within the range except for one hyperglycemia. Now, when I do a continuous glucose monitoring, you can see there are so many peaks, so many troughs or valleys which are missed by a SMBG. So self-monitoring blood glucose is something like a photo camera, and continuous glucose monitoring something like a video camera. So your video camera gives you better information regarding the trend compared to a photo camera. So continuous glucose data reveals reading that traditionally monitoring may miss. So this is a continuous glucose monitor, what you call AGM ambulatory glucose monitoring. This is just like a size of a coin, which could be fixed in your arm, posterior aspect. And you can have a reader, or you can have the app which is stored in your mobile phone also, where you can continuously see the value from the reader, this thing. For every 5 minutes, this sensor captures a reading which is transmitted to the reader. So the final result, what we get here is that something similar to that. So each color denotes 1 day. You can see overall blood glucose. If your target is between 70 to 80 to 140, you can see the target. Postprandial, there's a peak. Post-lunch, there's a peak. Post-dinner, there's a peak. It also gives you estimated A1C value. So this gives a more clear snapshot. Many times you titrate your breakfast, you reduce the breakfast by 30%, this peak will come down. Again, if you split your dinner 50% at 2 times, again this peak would come down. Or you change your food to a low glycemic index food or food with low glycemic load, your peak could come down. So many times having a continuous glucose monitor, it is very easy for us to titrate between the nutritional intake and the medication what the patient has been taking. So this could avoid unnecessary hypoglycemia or hyperglycemia for this patient. And see this patient, this is hypoglycemia which has been happening, and this is the hyperglycemia which has been happening. And these are the ranges where blood sugar is within the range. So final snapshot, what you could get is time above the range, time within the range, and time below the range. So now apart from your fasting glucose, postprandial glucose, HbA1c, we are banking more on time within the range, or what you call TIR. So now the guidelines are very clearly said at least 70% of the time your blood sugar should be within the range what has been recommended. So more than 70%, your blood sugar should be within the target range. Your target range commonly we say is 70 to 180 in most of the individual. And very few percent of the time they should have hypoglycemia, and very few percent they are allowed to have hyperglycemia. More the patient's blood sugar is within the target range, better is your end organ damage is prevented, because glycemic variability in turn can cause more and more of damage, especially to your neurons, to your retina, and also to your nephrons. And this advantage of CGM is that it can be worn for 14 days. So it's just a single prick for 14 days. It gives enormous information for us to control the blood sugar for our patient. So having looked at your diagnostic and monitoring criteria like HbA1c, like your fasting glucose, postprandial, SMBG, and I have introduced your continuous glucose monitoring with a time and range, how do you shift to the treatment? So initial teaching was that any obese patient, put them on metformin, any lean diabetic, you put them on sulfonylurea. And we were thinking only glycemic control is very important. And now the understanding of diabetes has totally changed, where your insulin resistance and beta cell dysfunction were initially thought as pathogenic mechanism. Now we understand incretins play a major role in your diabetic pathogenesis. It is not only insulin, it is a dancing partner of insulin. Glucagon also has a major role in diabetes management, because hyperglucagonemia increases the hepatic glucose output, and it also can increase the fasting blood glucose. Kidneys have a very, very important role in your diabetes management. Now we have SGLT2 inhibitors, which is available. So based on our understanding of diabetes, which has changed, our treatment focus also has shifted. So initially our treatment focus was on glycemia, control the blood glucose, control the blood glucose. That is what was said with UKPDS and DCCT study. So the concept of diabetes treatment on those days was just adding a OHA or insulin to a patient, apart from a lifestyle modification, which includes your diet, exercise, sleep, and stress-free life. Later came the concept of targeted control with medications as per protocol, which means your blood sugar should be within the target. If target is not reached, you go for step-up approach and you try to bring under control. And then the focus change towards your macrovascular benefit. So all your diabetic medicine, apart from glycemia, it should be able to have a cardiovascular outcome trial, or it should be cardiac safety. Now the data has moved towards you need a microvascular protection also. You need a renal protection. Now we understand cardiorenal metabolic disease is something similar to your diabetic management. So it's not only glycemia, but drug does matters in the diabetes management. And more important is that before starting any therapy for a patient with diabetes, we should assess and we should fix up the treatment plan. So assessing of diabetes complication includes atherosclerotic cardiovascular disease and heart failure, atherosclerotic cardiovascular disease and risk stratification, staging the chronic kidney disease, assess the hypoglycemia risk, assess for retinopathy, assess for neuropathy, and set your goal for HbA1c. Now, how do you set a HbA1c goal? This is very, very important, because unless you set your HbA1c goal, or unless you set your target, you cannot decide what pharmacological therapy would be useful for our patient. So to fix a HbA1c goal, you have various parameters which is taken into account, like risk potential with hypoglycemia, you look at disease duration, you look at life expectancy, other comorbidities, established vascular complications, patient preference, resource and support system. So resource and support systems are readily available, resource and support is limited. So based on that, you fix up HbA1c goal. Now, how exactly do you do it? Now, I have a patient with 42-year-old male, diabetes for more than 2 years, no comorbidities, teacher and Madurai. He's from Madurai. So risk potentially associated with the hypoglycemia is low. His disease duration is just 2 years. It is somewhat diagnosed 2 years only. Life expectancy is long because he's just 42. Comorbidities are absent. Established vascular complications are nil. Patient is a teacher, highly motivated. Resource, he's in an urban area. Resources are readily available. Now, when you put all these things, his HbA1c goal would be something around 6.5. On contrary, I have another patient, 72-year-old female, diabetes for 20 years, end organ damage, again teacher and village near Madurai. When you plot all this thing, her HbA1c goal would be 7.5 or 8. So your HbA1c goal depends on your other comorbidities and patient's profile. Now, based on this, your guidelines very clearly suggest what drug could be chosen. So once when you fix up a HbA1c goal, next you see whether this patient has atherosclerotic cardiovascular disease or whether the patient has a high risk for cardiovascular disease, which includes patients aged more than 55 years, risk factors like obesity, hypertension, smoking, dyslipidemia. In such case, you use a SGLT2 inhibitor or GLP-1. If not under target, you can go for other drugs. Similarly, when you have a heart failure or patient with CKD, again your SGLT2 is the preferred drug. Sometimes you look at drug with high efficacy, where again your GLP-1 and your SGLT2 would score better and your DPP-4 will come low. If you want a weight neutral, again these drugs will score better. You have semaglutide, tirzepatide, you have dulaglutide, all these drugs are better. So your choice of drug depends on what exactly is your goal. Now, whether to start on monotherapy or combination therapy, again, it depends on what you say initial goal. Suppose my HbA1c is 10 and my goal HbA1c is 7, my patient's blood sugar is 3% higher than that. So these patients would definitely require a combination therapy for most of these patients. So finally, your choice of drug, you have only 8 groups of drugs and roughly around 18 molecules. If glycemia control, metformin has a glycemia control, hypoglycemia is low, it is weight neutral, it does not have effect on blood pressure or lipid profile. When you look at SGLT2, it has benefits in all these things. DPP-4 has some benefit, sulfonylurea has some. So with this, I think probably your choice of drug depends on, you look at the baseline HbA1c, weight, cost, attitude of the patient, decide whether it's monotherapy or combination therapy, choose a drug with various pathogenic mechanism, ultimately having in your mind your cardiovascular, renal, hepatoabdominal, and infection chances of these patients. So your take-home message would be, we should know the diagnostic criteria of diabetes. The choice of OAD is individualized. Cardiometabolic benefits are as important as glycemia. Hit early, consider combination therapy if required. Patient to be looked as a whole and always monitor for your adverse events. Thank you. Thank you so much for your patient hearing.
Thank you, sir. Thank you, sir. It was a nice description, sir, regarding type 2 diabetes. So definitely it will be very useful to everybody. May I request Dr. Bharat sir, Associate Professor of General Medicine in Thoothukudi Medical College, to have his give his expert comments. Sir.
It is a nice topic, sir. As usual, the speaker talked excellently. Yeah, especially the explanation about CGM is very, very nice. So it is very simple and easily understandable way he explained CGM. And also the role of incretin and glucagon, so the developing in the treatment of diabetes. We talked about that also nicely. So only I have a question for Kumaravel, sir.
Yes, sir.
Any questions, sir?
So we have HbA1c target, but how can we adjust in relation to the hemoglobin level? Suppose the patient is having some low hemoglobin, so how can we adjust the HbA1c target?
I think hemoglobin, if you have anemia, your HbA1c may not be very reliable. You don't have a standardization for the level of hemoglobin and hemoglobin A1c. Plus, your HbA1c totally looks at your specific subset of glycosylated hemoglobin. So it may not be somewhere similar to your hemoglobin, what we routinely measure. But when you have severe anemia, your HbA1c could be falsely low. In such cases, you cannot totally depend on HbA1c. So you can use either fructosamine in those patients or glycosylated albumin in those patients, or you can go for the continuous glucose monitoring in those patients.
Is it a fructosamine? Is it available in the lab, sir, in our places?
It's available, sir. We do it routinely.
Thank you, sir.
Thank you, sir. Any more questions from audience? Okay. Thank you, sir. We'll move on to the next session. The next session is on approach to chest pain by Dr. Jim Litton. May I request Dr. Meenakshi Kumar to introduce the speaker?
So, good afternoon, everybody. I hope I am audible.
Yes, sir.
Yeah. So, warm greetings from IAP Marthandam. Very nice to be with you all.
Thank you, sir.
The session is going on very nicely. And our next topic is approach to chest pain. As you all know, we have like chest pain can be a cardiac or non-cardiac reason. So, and we are more concerned about cardiac cause chest pain, and especially in the post-COVID era, we are seeing more number of cases, especially young people getting myocardial infarction and other complications. So I think it's the right, the organizers have chosen the right topic. And I'm proud to introduce our IMA Marthanam member, Dr. Jim Litton, who's a physician and consultant physician in many institutions, including NIMS Hospital Neyatankara. So he's a well-versed person, knowledgeable, and I hope you all will benefit from his talk about approach to chest pain. Over to Dr. Jim Litton. Thank you.
Thank you, sir, for your kind words. Hope I am audible now.
Yes, sir.
Yeah. Is my screen visible?
Yes, sir. The screen is visible.
Yeah. Good evening, everyone. I thank IMA Tirunelveli for giving this opportunity to speak in this forum. We all know that chest pain is a very wide topic. However, I will try to give some of the most important aspect of the same in the very given short period of time. These are the contents of this presentation. We will be looking at the introduction, differential diagnosis, clinical approach, history examination, and then we will discuss a little about some of the life-threatening causes of chest pain. We know chest pain is one of the most common symptoms presenting in emergency department. So there's a wide range of differential diagnosis, which is life-threatening and non-emergent condition. Life-threatening like acute coronary syndrome, pulmonary embolism, aortic dissection, pericarditis with tamponade, pneumothorax and esophageal rupture. And non-emergent condition include esophageal reflux, peptic ulcer, biliary colic, costochondritis, and pneumonia and non-specific chest wall pain. And this is the data from our country. About 5 million emergency department visits comes because of chest pain. 2 million hospitalizations are done annually due to chest pain. And cardiac etiology is found only in 1/3 of them. and almost 2% of the people with acute MI are unrecognized and discharged from the emergency department. So every physician who is treating the patient with chest pain should know how to differentiate between cardiac and non-cardiac and emergency cause and non-emergency cause for chest pain. I'll be dealing with the differential diagnosis and incidence. And this is just a graph which shows the different cause of chest pain. We can divide it into cardiac, pulmonary, gastrointestinal, musculoskeletal, and psychiatric and neurological. In cardiac, we have the vascular causes, valvular causes, and aspergillus from the heart. The vascular causes includes acute coronary syndrome, stable angina, dissection, and aneurysm. Well, valvular causes can include aortic stenosis, mitral valve prolapse. And as per the heart, we have pericarditis, myocarditis, and cardiac tamponade. The pulmonary causes, the important causes include pneumothorax and viral pleuritis. Also, pneumonia and tuberculosis form some of the most important causes in our country. Well, GI causes, the biliary causes include cholangitis, cholecystitis, and esophageal spasm is another condition which most of them we used to miss, and GRD is frequent in our country. And peptic ulcer disease and pancreatitis are the other important causes in coming under gastrointestinal. And musculoskeletal causes include costochondritis, sternoclavicular arthritis, rheumatic disease, and when we look at the bone, it's a fracture or cervical disc disease. And psychological causes mainly include anxiety, symptom disorder, and neurological causes. Herpes zoster is one of the most important causes. So when you look at the clinical approach to chest pain, history is one of the most important steps when we look at chest pain, because once we focus on history, we can almost get about 70% of the diagnosis from the history itself. So we should look at the characteristics of the chest pain. Suppose the patient presents with very sharp chest pain, it could indicate the patient might have pericarditis or herpes zoster. If he complains of squeezing or dull or heaviness or pressure of the chest, it could be mainly because of angina or could be MI. Stabbing type of pain is present in pericarditis, while pleuritic pain in lung conditions like pneumonia and pulmonary embolism. However, some patients present with very severe pain, which is compared to that of tearing of heart, and it's suggestive of aortic dissection. And burning type of chest pain is more seen in GRD, and band like shooting pain is more suggestive of nerve root pain. So this is regarding the characteristics of the pain. Moving on to the site and radiation. Once the pain is localized, we all know that some pain will be radiated to some sites. So most importantly, aortic dissection, peptic ulcer disease, and pancreatitis can radiate to backside. Well, nerve root pain, it's like around the chest wall and results like a band-like pain sensation. As I mentioned previously, cardiac ischemic pain may be central and can radiate to jaw, neck, or towards the left hand. And respiratory chest pain, it localizes to the site of pathology, usually a source of infection or pneumothorax. Musculoskeletal chest pain is localized to the site of the pathology or injury and may relate to the posterior chest wall or the region of the spine. And peptic ulcer disease and gastroesophageal reflux disease mostly present with chest pain at the lower chest and epigastrium. So this is regarding the site and radiation. There's something regarding onset of pain. So we can also have some different diagnosis with the onset of pain. Suppose a patient presents with a sudden onset of chest pain, it could be mainly because of MI or pulmonary embolism, pneumothorax, or aortic dissection. These are some of the very severe causes which can cause sudden onset of chest pain. Well, gradual causes of chest pain could be due to musculoskeletal causes, from GI causes, and pneumonia, herpes zoster. And the duration is also important. For some people who present with stable angina, they'll be having chest pain in between 2 to 10 minutes and gets relieved. So some with unstable angina and MI can have chest pain for about 30 minutes. And some with more than 1 hour of pain which is persistent can be because of esophageal spasm, which is because of the abnormal muscle contraction of the esophagus. And few hours, it can be to pneumothorax and pulmonary embolism. And hours to days is pericarditis, and longer it's like the neurology of herpes zoster. So all these pain can overlap with each other. There is no definite duration of any pain, but we should just have an idea to think about some of the causes of the same. And we should also ask about the precipitating factors of the same. So in case of cardiac ischemia, the pain will be more on exertion, and in deep inspiration, if the pain increases, its patient might have respiratory, musculoskeletal, or pericarditis. And more on movement, most probably it's musculoskeletal. And pain after eating, it could be peptic ulcer disease or GERD. And by positional change, if the pain increases, so likewise, in pericarditis and pancreatitis, patient might have severe pain on lying down, and bending forward, it can exacerbate GERD. So pericarditis and pancreatitis are some of the pain which can almost get by asking the history. And relieving factors is another important point. Cardiac ischemic pain usually relieves by rest, and sublingual nitrates when given can cause cardiac ischemic pain, and esophageal spasm also to get reduced. Antacids can reduce peptic ulcer disease and GERD, and musculoskeletal pain and respiratory pain pericarditis can also be relieved by analgesics. And those people who have pain, who are already asthmatic and OAD, they can be relieved by bronchodilators. So these are some of the other ideas or important steps which we should know regarding diagnosing what kind of pain the patient presents. The associated symptoms which the patient presents with the chest pain is also important, because cardiac pain can also have associated symptoms like nausea, vomiting, sweating, pallor, or breathlessness. It's mainly because of the manifestation of ischemia or left ventricular dysfunction. However, some patients can also present with palpitation and dizziness. It could be secondary to arrhythmia. And some patients can present with features of left ventricular dysfunction like orthopnea, PND, and edema and reduced exercise tolerance. So some of these symptoms are mainly associated with cardiac type of chest pain. Respiratory tract infection pain could have cough, which is productive or non-productive, and sputum production, fever, and hemoptysis. And pulmonary embolism is another important cause, because the patient might have cough, but it could be non-productive. The patient can have hemoptysis and low-grade fever sometimes. And we should definitely check for lower limb thrombosis, deep vein thrombosis in pulmonary embolism patient, because most of the patient might be having the deep vein thrombosis in their legs. We should also ask about the history of over long periods of rest or post-surgical case in this case. And in lung malignancy, it can also, the patient can also have cough with hemoptysis and weight loss and loss of appetite. Pericarditis patient can also have flu-like symptoms along with the chest pain. Nausea, vomiting, and hematemesis and melena are present mostly in peptic ulcer disease. And GERD, a patient can complain of acid taste in mouth or dysphagia. And musculoskeletal pain, back and joint pains, and symptoms of underlying malignancy, suppose the patient have, we should check for the patient for weight loss, loss of appetite, change in bowel habit, and noticeable mass or lumps. And neurological symptoms in lower limbs, urinary and fecal incontinence can have spinal cord involvement. So these are some of the associated symptoms. Moving on to physical examination. I'm not covering everything. I'm just telling about some of the important things we should note. The vital signs is the most important thing which we should first look properly. Hypotension can occur in MI, pericardial tamponade, pulmonary embolism, and GI bleed. So if the patient is hypotensive and if the patient has chest pain, we can't just rule him as like some say gastritis. We should admit him and evaluate him for the same. And fever also suggests an infectious disease is in progress. On inspection and palpation, we can find out if there's a fractured rib or localized tenderness for costochondritis, or if there's signs of trauma. And some people may have a neuralgia of this herpes zoster, and that can be also found in inspection. And hyperesthesia, particularly when associated with the rash, is often due to herpes zoster. And cardiopulmonary embolism examination is another important part of physical examination. In MI, people, we can also have an audible S4 in signs of left ventricular failure with S3. And pericarditis, we can have friction rub and pulsus paradoxus. There is a reduction in systolic BP during inspiration. And also Beck's triad is something which we should keep in mind. The JVP is elevated and muffled heart sound and low BP, which suggests cardiac tamponade. And if suppose the patient has variation of BP in both the limbs, then we should suspect aortic dissection. And we can also determine whether if the breath sounds are symmetric or if it's asymmetric, and if there's wheeze, crackles, or any reduced air entry on one side, which can suggest other causes of chest pain, significant cause of chest pain. Moving on to diagnostic evaluation, we all know that ECG is an important marker and a diagnostic test for chest pain. And other cardiac markers, we include troponins just to rule out any severe important life-threatening cause of chest pain. These are the enzymes which rise initially and can remain elevated for about 5 to 14 days. An echocardiogram can help in diagnosing of pericardial effusion and valvular heart disease. Chest X-ray, mainly in pneumothorax and also in pneumonia. In pulmonary embolism, only if we suspect, we can do CT pulmonary angiogram. And in other blood includes our basic blood investigations like CBC, RP, RFT, LFT, and urotin, and ANA, RI factor, uric acid in case of musculoskeletal pain, we can rule out if the patient has any significant arthritis. And in case of GRD, esophageal pH monitor is indicated. However, this is not routinely done in our country, and patients with musculoskeletal chest pain sometimes might not need any diagnostic testing. So moving on to a discussion of some of the life-threatening causes of chest pain, I will be discussing these five types of life-threatening causes. And these causes we can't discuss. These are very vast topics. However, I will just discuss some of the important points for the same. The pulmonary embolism. So pulmonary embolism, we all know that it occurs when a blood clot gets stuck in the lung and there is a blockage of blood flow to a part of the lung. So patient presents with sudden onset sharp pain of the chest. It can be exacerbated by inspiratory effort, and it can be associated with hemoptysis, syncope, or dyspnea. Patient can also have leg pain, suggesting DVT. So on examination, patient can be anxious, and patient can also have a sense of impending doom. The monitor can show tachycardia, patient can have tachypnea, and hypoxia can also be there. If the patient has severe blockage, it can lead to hypotension, syncope, and also features of right ventricular failure like elevated JVP and right ventricular heave. So these are some of the important examination aspects in case of patients who present with chest pain, who are suspected to have pulmonary embolism. Investigation, ABG can have reduced PaO2 and PaO2 from increase in overall ventilation. And D-dimer is sensitive to, but it has a very low specificity for pulmonary embolism. Even in sepsis, D-dimer is elevated. And in other many causes, D-dimer is elevated. So we should not order D-dimer directly to rule out pulmonary embolism. Chest X-ray is often frequently normal. However, in some people can have atelectasis and pleural effusion. Rarely, some people can have a Hampton sum. That's the area of infarction. When the part of lung infarct, and we will see a sum like this. It's called as the Hampton sum. It's very rare nowadays to find. ECG, we all have studied. ECG can show S1, Q3, T3, but even this is very rare. We should also look for right axis deviation ECG. And we should consider Doppler, bilateral lower limb venous Doppler to rule out any bilateral lower limb deep vein thrombosis. And CT pulmonary angiogram can definitely find out the extent of the pulmonary embolism. Here, this picture is we can find out the pulmonary trunk is dilated and there's a big saddle embolus, which is obstructing the pulmonary artery. So normally the management, if the patient is hemodynamically stable, thrombolysis is the main important management which is done nowadays. And nowadays catheter-directed thrombolysis is done, in which the catheter is directly sent to the pulmonary artery and near the area of pulmonary embolus, and only a little amount of thrombolytic agent is used. So this kind of catheter-directed thrombolysis is very useful because it does not have side effect and does not have any systemic effects of thrombolysis. And it is considered safe nowadays. And the patient should be managed with anticoagulation to prevent further thrombosis. And previously, we used to give heparin and overlap with warfarin to maintain an INR of 2 to 3. And nowadays, newer oral anticoagulants such as rivaroxaban can be also given, for which the INR need not to be checked upon. Moving on to the second one is IAP dissection. The patient may present with sharp tearing anterior or posterior chest pain. It's typically sudden onset and severe, and chest pain is more common with type A dissections. There are actually three types. Type 1 is dissection of ascending and descending thoracic aorta. And second is type B is type 2 is dissection of ascending aorta, and type 3 is dissection of descending aorta. So IAP dissection is the tear of the innermost layer of the aorta, which allows the blood to flow between the layers of the aortic wall. The diagnosis is made by history and physical examination. The most important thing which you should notice here is that the variation in pulses or blood pressure. If we measure blood pressure in both arms, if there's a subsequent difference between them, between the right and left arm, we should have a differential diagnosis of IAP dissection in mind. ECG is variable and it depends on complication, and we don't have much important finding from ECG. When the imaging can be done when the patient is stable, then chest X-ray may show mediastinal widening, and CT chest, transesophageal echo, and MRI are other options which are all very superior for diagnosis. This is a patient with IAP dissection. Here we can see there's a mediastinal widening, and this is something called the calcium sign, which we can find in X-ray. There's a separation of the intimal calcification from the outer aorta soft border, more than that of 1 centimeter. So some other findings which that can be found is tracheal deviation and esophageal deviation, aortic knob enlargement. But these are some of them findings are very difficult to find in X-ray. And most important thing is this mediastinal widening. The echo can definitely help in diagnosis of aortic dissection, where we can demonstrate there's a flap which divides the aorta into two. That is a true lumen and there's a false lumen. And by using Doppler, we can find which is true lumen and which is false lumen. And also the CT chest can also show the same. The management is by, for pain control, morphine can be given. The most important thing is to reduce the systolic BP and also heart rate to less than 60. And before giving beta blockers, we should also check for the other medications the patient is taking. And if patient is already hypertensive, we should look for blood loss or tamponade along with this. So there's also surgical management is the main thing in type A, and type B and uncomplicated is medical. And if it's complicated, further surgical management is done. And long-term management includes beta blocker and serial imaging at 3, 6, and 12 months, and a reoperation if indicated. Moving on to pericarditis, it is another important cause which we should think of when the patient presents with chest pain. Patient can have anterior chest pain with sharp pleuritic exacerbation. It can be decrease with leaning forward, and the pain can reduce to trapezius. So in pericarditis, it can have multiple etiology like viral, bacterial, and autoimmune. However, in India, tuberculosis is the most common cause of pericardial effusion. And pericardial chest pain is the most important symptom. Friction rub can be heard, and ECG changes is the one we should never miss. ECG can have widespread ST elevation with PR depression in almost all leads. And we should consider tamponade if the patient have sinus tachycardia with pulses paradoxus, and that is reduction of systolic BP on inspiration. And these are some of the early changes during the initial stage to final stage. Initially, there will be ST depression, then followed by ST elevation, and finally widespread ST elevation in all ECG leads. The treatment for pericarditis is mainly NSAID and colchicine. And previously, use of corticosteroids have been controversial. However, nowadays, NSAIDs and colchicine and ATT should be started because most of the patients with the diagnosis of pericardial effusion have TB. It should be treated, or should be diagnosed. It can be started. And tamponade should be suspected when the patient have very reduced pulse, and we should also have serial echo monitoring. And the treatment of tamponade is by treating the underlying cause, and also this is that of pericardiocentesis. It depends on the condition of the patient. And moving on to acute coronary syndrome, it's a very vast topic. However, we should just know some of the important points. The unstable angina, patient have rest angina, usually lasting more than 20 minutes duration. New onset severe angina can also be present, and the patient can also have increasing angina, and angina will not be relieved by nitrates. Patient can also present with unstable angina post-MI. And other type of ACS includes the STEMI and STEMI. The signs of acute coronary syndrome mainly have signs of sympathetic activation and signs of vagal stimulation. The signs of sympathetic activation include pallor, sweating, and tachycardia, and that of vagal stimulation include vomiting and bradycardia. So some patients who present with chest pain with severe sweating and vomiting and bradycardia, we should definitely think of ACS. And signs of impaired myocardial function should be also be kept in mind, which include hypotension, oliguria, and cold peripheries, and narrow pulse pressure, and raised JVPs, another important thing we should keep in mind. And as mentioned earlier, S3 and quiet S1, and diffuse apical impulse and basal crepitations in failure. The investigation, ECG is the most important investigation, but in some people with previous MI and old bundle blocks, it's difficult to interpret. And about 1/3 of the MI cases, initial changes may not be diagnostic, and the earliest changes could be ST elevation, and later poor R-wave progression can be present. In transmural MI, however, Q waves can be present and T-wave inversion. This is the ECG which shows ST depression and dynamic T-wave inversion, and another ECG with STEMI, acute rhinal infarction. And those people who present with chest pain and left bundle branch block, we should not leave them. We should definitely admit them and evaluate, because a patient with the left bundle branch block can definitely have acute MI we should use Sarbosa's criteria to diagnose MI. Recently modified Sarbosa's criteria used for this to suspect STEMI in any case of LBBB. We should check the ECG for concordant ST elevation of more than 1 millimeter in any leads, and also concordant ST depression greater than 1 millimeter in leads V1 to V3, or ST elevation by S-wave height is greater than 25% in any of the leads. Suppose the ECG has any of this, then we should definitely consider the patient will be having suspected STEMI, and we should admit and evaluate the patient. Plasma biochemical markers, the most important marker which is troponin, TNI, and we all know that it rises in 4 to 8 hours. Other markers include myoglobin, but it's not very specific. It can also be positive in skeletal muscle injury. This is just
Excuse me, sir.
Yeah.
Yeah, we are running short of time, sir.
Yeah, just it's the last slide.
Thank you.
So this is the flow chart which shows the STEMI management. Those person presenting with STEMI, if they are brought to a PCI capable hospital, we can directly send them to primary PCI if the contact time is less than 120 minutes. However, in non-PCI capable hospital, after giving the loading dose, we can check for indication for contraindications to thrombolysis, and we can definitely do thrombolysis. If thrombolysis is successful, then we can shift them for angiography in 3 to 24 hours. If there's a failure, we should immediately transfer to rescue PCI. And finally, pneumothorax, I will just tell upon the tension pneumothorax. It is the most important type of pneumothorax, which we should be more careful. The patient can definitely deteriorate within a short period of span. And some of the physical examination can be unilateral chest movement, trachea may be shifted to one side, and physical examination also have percussion note which is hyperresonant, and breath sounds are reduced on one side. Treatment option mainly depends upon the classification pathogens and severity of the disease. And most other treatment option include aspiration, catheter aspiration, chest tube drainage, and thoracotomy with video-assisted thoracotomy and open thoracotomy. And this is the slide which shows all the severe causes of chest pain. And thank you everyone for.
Thank you, sir. Thank you for your wonderful speech. So may I request Dr. Badusha sir to give his expert opinion.
Yes. Thank you very much.
Thank you, sir.
I think this is a nice presentation. Unfortunately, we didn't have enough time to explain everything. But I think whatever he has covered is really a good point for everybody, because we always worry only about ACS whenever they come with chest pain. You need to make sure that all the junior doctors make sure that the chest pain is not only acute coronary syndrome. So it could be a respiratory related or aortic dissection related, or pulmonary embolism, or pericarditis. So you need to make sure that you have to have a rule out all these things as we clearly explain everything. Hello?
Yeah.
Yeah, I think somebody has muted me. I think he has covered most of the things for the chest pain one. As far as I'm concerned, I think nowadays the pulmonary embolism is, I'm seeing a lot of patients with the pulmonary embolism. That is because the dangerous one, if we don't diagnose and treat them as early as possible, we might lose the patient. So you always have a low suspicion, particularly when echo shows like right heart, a problem like dilatation or pulmonary pressure, low saturation, and you probably think of pulmonary embolism and do the necessary things for the early treatment to save the patient. I think all the others he has covered very well, nothing more to add. Anyway, it's a nice presentation.
Thanks.
Thank you, sir. Any questions from audience? Thank you, Dr. Jim Linton and Dr. Badusha sir, who is a senior interventional cardiologist in Tirunelveli. We'll move on to the next session. The next session is on PPI abuse. The speaker will be Dr. Radha Madam, who's Secretary Rajapalayam, IMA branch. And the moderator will be Dr. Jawaharlal sir, President of Rajapalayam IMA branch. Then the expert comment will be from Dr. Shafiq, Assistant Professor, Department of MGE, Tirunelveli Medical College. Over to Radha Madam.
Good evening, sir. Are you able to hear me?
Yes, madam.
Thank you, sir.
Myself, I am Dr. Jawaharlal, President of IMA Rajapalayam branch, sir. It's my privilege to introduce Dr. Radha. It's a good topic. Abuse of PPI, proton pump inhibitors, is often prescribed over the counter, and the patients themselves know most of the drugs, and they take themselves for bloating and other conditions. Therefore, it is my privilege to introduce Dr. Radha. Dr. Radha has completed his MBBS in the year 2000 at PAG Medical College, Coimbatore, and MD in Government Medical College in Trichy, and DM Gastroenterology completed in the year 2013 in Chennai. And she worked in Chennai for about 5 years in Fortis Mother Hospital. And now she is doing the private practice at Rajapalayam for the past four years, sir. And she is doing a good work in Rajapalayam branch, sir. Over to Dr. Radha.
Thank you, sir. Thank you for your kind introduction, sir. And I thank IMA for giving me this opportunity to talk about PPI in this online CME. Now
is on stress busters for doctors. So the speaker will be our AMS secretary, Dr. Paneerselvam sir. So moderator will be Dr. Sivasailam sir, who is secretary of Thoothukudi IMA branch. An expert comment will be from Dr. Ramanujam, associate professor, Tirunelveli Medical College, Department of Psychiatry. So move on to Dr. Paneerselvam sir. Before that, shall I ask Dr. Sivasailam sir to introduce Dr. Paneerselvam sir?
Thank you, Dr. Prabhraj sir, for your kind introduction.
Thank you.
It's a great privilege and honor to introduce the today's speaker, Dr. Paneerselvam sir. Sir completed his MBBS from Tirunelveli Medical College, and he completed his MD Psychiatry from NIMANS, Bangalore. So he is practicing in Tirunelveli for the last 2 decades. And he is one of the leading psychiatrists and a good friend of mine. He is one of the leading psychiatrists in Tamil Nadu. And sir is currently he is the director and chief psychiatrist, Sneha Mind Care Center, Tirunelveli. And he is the immediate past president of our Indian Psychiatric Society Tamil Nadu chapter and secretary AMS Tirunelveli branch. Sir, the forum is for you, sir. Dr. Paneerselvam sir. Thank you.
Thank you, Dr. Sosana. Is my screen share? Can you see my screen?
Yes, sir.
Thank you. Thank you,
yes,
Dr.
sir,
for your kind introduction. And I thank Dr. Subramanian, the president of Tirunelveli IMA, for giving this opportunity to talk in this esteemed forum. So I'm going to talk about the impact of stress on doctors and how we have to overcome that. So does the mental health really matters for the doctors? The answer is yes. India is witnessing an alarming rise in the premature death among the doctors. A recent study by Anil Kumar et al. Reports that an Indian doctor's average lifespan is almost 10 years less than that of the general population. The general population age, the lifespan is around 69 to 72 years, whereas our doctors' lifespan is only 55 to 59 years. And also, the suicide rates in Indian doctors are 2 times more than the general population. And very often you can see the doctor suicide news in newspaper and WhatsApp. We can also hear about the young doctor's sudden death also. You can see this newspaper, Pen Doctor Thurku Potu Tarkolai, Tanime Karnamaga Virakti Mudivo. A 24 years Chennai doctor dies by suicide in Stanley Hospital. Nachitra Hotel, Visa Usi Potu, Doctor Tarkolai Kadethil. So these kind of news we can commonly come across in the newspapers and also in the social medias. The hospital were considered as a temple and the doctors were treated like a god in the past. But today there is a shift. Doctors are no longer treated with the due respect. They are considered as the businessmen and the profit makers. The medical profession is one of the most stressful occupations. According to a research study, 30% of the Indian doctors go through depression, 17% have experience of suicidal thoughts, almost 80% of the doctors are at the risk of burnout. So mental health problem, when compared to the general populations, doctors have a high rate of mental health problems. The general population only have 10% of risk, whereas doctors have 30% risk. The mental health problem like depression, anxiety, addicted to alcohol, misuse of the prescription drugs like sedative drug like alprazolam, clonazepam, lorazepam, and also the burnout. A recent published article in the Indian Journal of Critical Care Medicine reports that 21% of the doctor consume alcohol in higher volumes, 18% are dependent on antidepressant, 14% are heavy smoker. Even doctors, advise and nurses who work in the ICU routinely report auditory hallucination, meaning that they hear the emergency beep sound when they are not at work. So Indian doctors are under high pressure and they have many stressors like working for very long hours. Indian doctor works for our 8 to 12 hours per day, whereas the expected work time for the doctors only 5 to 6 hours. Our Indian doctors working for very long hours, 8 to 12 hours per day. There is high expectation from the patient, the relatives. The public is putting much unrealistic pressure on doctors. Verbal, emotional, sometimes physical abuse are also at the hand of the patient and the caregivers. And also the patient doctor's personality traits like excessive supervision. They want to do everything in a perfect manner, excessive sense of responsibility, desire to please everyone, and fear of litigation are some of the reasons for the poor mental health among the doctors. When you look at the burnout of the doctors, that critical care physicians and the neurologists, they have a highest burnout, whereas the dermatology and plastic surgery, they have a lowest burnout, and the intermediate burnout are the ENT surgeons, pulmonologists have an intermediate burnout. You can see the list of doctors who have the degree of burnouts is listed here. And despite the elevated presence of mental health issue among the physician, but unfortunately, doctors are often reluctant to seek the mental health treatment. Because they have fear of stigma, fear of discriminations, fear regarding the confidentiality, and many of the doctor report that they have a lack of time to take care of their mental health. 91% of the doctors says that they don't have time to care for the mental health issues like anxiety, depression, or substance abuse, and they prefer to manage themselves with their own. 75% of the doctors, they used to treat their problem by their own. For example, they have an anxiety, they'll start taking alprazolam 0.5. After a couple of years, they will be up to 1 milligram or 2 milligram alprazolam. Similarly, many doctors were on benzodiazepine for many long years. So why should the doctors to concern about the stress? WHO reports that stress and depression is the second leading cause for premature death and disability among the worldwide. That is including for doctors also. Unattended stress and depression can lead to loss of happiness. You may lose our peace and have an interpersonal problem with the wife and children, and the sedentary lifestyles are all lead to stress and depression. The stress and depression is an independent risk factor for developing the diabetes, hypertension, hypercholesterolemia. All these are lead to the risk factor for developing the ischemic heart disease and cerebrovascular accident. So stress buster. Many of us work for a very long hours, work for 10 to 12 hours per day. Many of the doctors are workaholic. They often don't spend the time for themselves. But it is very important to make the time for ourselves. We should always make our time. That's called meal time. The doctor should take a time for relaxation. They should have take time for exercise, socialization, and should spend quality time with their family. To have a stress-free, always stay connected. So always stay connected with your colleagues, your friends, and the family. And connecting with these people, with others, can lower your stress level. It helps you to see the things differently. The research evidence shows that activities and quality time spent with your family and friends can help you to feel relaxed and also get relieved from the stress. And always share and express your feelings with others. Always talk to others. Don't keep your emotion within yourself. Ventilate your negative emotions to others. Share your feeling with whom you trust. And ventilation can help you to lower your stress level. And another important thing is to do an exercise. The physical activity play a vital role in stress management and keep you healthy. Make time for at least 30 minutes of exercise regularly. The physical exercise can improve your stress and depression. Daily 30 minutes of exercise for at least 3 to 5 days per week may significantly improve your stress, depression, and anxiety. The exercise intervention consists of a simple brisk walking for 30 to 40 minutes, 3 to 5 times a week can elevate the overall symptom of depression and anxiety. Every day you do 30 minutes simple exercise, walking, jogging, cycling. You do it for at least 5 times per week. You do it for at least minimum 6 weeks. They can feel that their stress level has come down. Even it says that scientific evidence says that it can exercise for 30 minutes for 5 times per week, at least for 2 months, it reduces the depression also. So regular exercise can reduce the stress hormone and release the happy hormones like endogenous endorphin and monoamides. So exercise have a variety of advantage. It increase the production of the neurochemical that promote the brain cell repair. It improves your memory. It improves your attention span. It helps you to the decision-making skill and improves the multitasking and planning. So now also you have to learn to relax your mind. So study shows that diaphragmatic breathing may reduce your stress, anxiety, and depression. Practice 4-7-8 breathing method to reduce the stress. You close your lips and inhale through your nose for count 4. Inhale 1, 2, 3, 4. Then hold the breath for to the count of 7. 1, 2, 3, 4, 5, 6, 7. Then exhale completely through your mouth to the count of 8. This consists of one cycle. Do 3 cycles at least 4 or 5 times per day. It will help you to relieve your anxiety as well as depression. Deep breathing stimulate the vagus nerve, and that's a phrenic nerve. We all know that vagus nerve is the longest cranial nerve. It passes from the midbrain to the diaphragm. If you stimulate the vagus nerve by deep breathing, and it decreases the sympathetic activity, so it decreases the heart rate, it decreases your respiratory rate, and decrease your muscle tension, and also it decreases the stress hormone called cortisol. When you do a relaxation exercise, when the vagus nerve is stimulated, then it decreases the stress hormone. You can feel happy. If vagus nerve stimulation, for example, in the severe depression, vagus stimulation tend to reduce the depression. So you do all these things. And also, scientifically, yoga is proved to be effective in anxiety and depression. Yoga has three which includes pranayama. Pranayama means breathe control, then asanas, that is physical postures, and third is meditation, that is dhyana. So if you do the breath control, asanas, and meditation, all these are scientifically said to have effective in reducing the stress and anxiety. Yoga can also reduce your heart rate, it lower your blood pressure, it ease breathing, and also increase the pain tolerance, and also said to be decrease your level of blood. So eat well, and sleep well. So stress and sleep go hand on hand. And many doctors do night calls. They sleep irregular. They have a irregular sleep and inadequate sleep that lead to depression. So for a healthy mind, you need to sleep at least 7 to 8 hours a day. Don't compromise on sleep. So intellectual illness also will be needed to relieve our tension. Reading can relax your body in lowering the heart rate and reducing your muscle tension. A 2009 study at the University of Sussex found that reading can reduce your stress up to 68%. But no gadget reading. Read from the books. Paper reading is good. The excessive screen reading can lead to digital eye strain and impact of the sleep cycle. Even excessive screen time can known to increase your anxiety tension. So avoid reading from the gadget as far as possible. Try to read from the. So seeking professional help also very, very important. It is crucial for the doctors to recognize when there is need of professional help. If you have anxiety, depression, if you have addicted to some substance abuse, or if you have any psychological issue, don't hesitate to consult a psychiatrist or psychologist. Usually doctors can learn many things if they consult a specialist like us. So they will help you to address your problem, mental health conditions. They will guide you in a proper manner than say self-medication for yourself. or you self-treatment for your mental health problems. Don't hesitate to consult a doctor, a psychiatrist, or a psychologist. So keep balance among the family, work, leisure, and friends, and may be active. So one of the things for stress management is always you have to be very active. If you are in the OPD, you're sitting for more than an hour, take a short walk around the office. And if you're sitting for more than an hour, you stand up, you stretch for few minutes, do some breathing exercise. And these small things will make you keep you stress free. And always use staircase. Don't use lift in your hospital or wherever you go. Always use the staircase. Don't use lift. And engage in recreational activities. Whatever you like, engage in activities apart from routine your professional work. So if any person will want to be very happy, always need four chemicals. That four hormones. One is dopamine. If you buy a car, you have established your practice, you purchase a car, you purchase a home, you get your children are getting married, then you feel very happy. The hormone response for the dopamine. Another important thing is a physical exercise. When you do a regular physical exercise, as I said earlier, daily 30 minutes exercise, you do it at least 5 times per week, at least for 6 to 8 weeks, then it will increase your endorphin level. You can see many doctors, you can exercise பண்ற doctors, yoga பண்ற doctors, நீங்க காலையில பாத்தீங்கன்னா they feel very energetic, they feel relaxed when they come for the OPD. The hormone responsible for this endorphin. Another important thing is to engage in social work. Apart from your clinical practice, you engage in Rotary Club or Lions Club or any social activities. You engage in that. That also relieves your stress, it produces happiness, the hormone responsible for the serotonin. And the fourth one is you have to be socialization. Be socialist with others. So be socialization, you work others, you say handshake with others. If you do that, the oxytocin hormone will secrete in your body. That will reduce your stress, and also it produces happiness for you. It is not a stress that kill us, it is our reaction to it. A diamond is a piece of charcoal that handles the stress exceptionally well. This is my last slide. The Dalai Lama, when asked about what surprised him most, humanity, he answered man. Because man sacrifices his health in order to make money. Then he sacrifices money to recuperate his health. And then he is so anxious about the future that he does not enjoy the present. The result being that he does not live in the present or the future. He lives as if he is never going to die, and he dies having never really lived. So there's no health without mental health. So doctors, please mind your mental health, give importance to your mental health along with their physical health also. Thank you very much. Thank you. Stop, sir.
Thank you, sir. Really, the topic is need for the hour, and you have elaborated very nicely, sir. Definitely, it will be a very good topic for all our doctors, especially for young doctors, sir. Dr. Ramanujam, sir, may I request you for a few words, sir?
First of all, thanks for IMA and Dr. Meerselvan, sir, and congrats to Meerselvan, sir, for having a wonderful, good presentation. He has elaborated, giving us the epidemiology, how common, they say doctors are the worst patients, and it is also said that doctor heal thyself in Bible. So he has elaborated what makes and what are all the ways, especially exercise, avoiding sedentary life, and food, and importance of sleep. I also want to stress that he not only preaches, and Paneerselvam sir practices what he preaches, and he involves in activities, especially connecting with people. So thank you, Dr. Paneerselvam sir, for giving us this wonderful lecture. Hope all the participants get it.
We'll move on to the next topic. The previous topic, it was PPI abuse by Dr. Radha Madam. Over to you, Radha Madam.
Thank you, sir. I just want to give the lecture audio lecture, so thank you. So proton pump inhibitors are often misused and overused, which can lead to a number of adverse effects. So what are the indications for PPI? So indication for PPA is GERD and acid-related disorders and erosive esophagitis, Barrett esophagus, and prevention of GA bleeding while on NSAIDs, and eosinophilic esophagitis, peptic ulcer disease, and stress ulcer prophylaxis in critically ill patient. So the significant use of PPI, why the PPI is abusing, because have a ill-defined indication over the years. We have routinely started using the PPI for all the tablet we thought like we are using with NSAIDs. We are using, it's a routine combination prescription for every physician or every doctor's prescription. Like when you're using a COX-2 inhibitor or NSAIDs or any long-term use of any drug, we start using PPI along with this. We should not use like this because it has a adverse outcomes, more serious outcomes are reported. So the adverse outcomes related to the gastric acid secretion and non-gastric acid secretions. So adverse unrelated to gastric inhibitions, like the common adverse outcome is acute intestinal nephritis, because the PPI has an inflammatory products when you're reaching the kidney, and it has stagnant in the kidney and is caused the intestinal nephritis, and it also has an allergic reaction and is precipitate, and it increase the probability of the CKD, and it has a poor cardiovascular outcome also is there. So when you have when the patient long-term PPI, so the long-term hypoglycemia, like when you have a decreased secretion of acid, and there is more prone for infections like gastrointestinal infections, pneumonia, nutritional deficiencies, and the other one of the most underrated adverse event is like more prone for fractures. When you take with increased age and more number of medication, and it will cause hypocalcemic state and it cause fractures. So when you using the PPI with other medications like metformin and diuretics, concomitant use of PPI with metformin is a common prescription for the sugar patient. But you should not use PPI and metformin because it will diminish the absorption of B12 and resulting in a B12 deficiency and more anemia and more nutritional deficiency. And you should not use PPI and diuretics and unnecessary, because the risk of hypomagnesemia is there. So whenever you use the PPI, you always have the feeling of PPI, like a feeling of side effect in your mind. Like it has a more risk of cardiovascular risk. Like it increases the risk of the myocardial infarction, stroke, and cerebral vascular accident, and has outcome with renal problems like AKI, and is increased risk of fracture and increased risk of infection, and increase the micronutrition deficiencies. Always look for B12 deficiency and anemia, hypocalcemia and hypokalemia. And it also has the increased risk of cancer, like gastric cancer, pancreatic cancers, and colorectal cancer, and hepatic cancers. It increases the risk and over a long-term use. So when you say it's a long-term use, how much the long-term? Long-term, they define like from 2 weeks to 12 weeks. The maximum you try to stop the PPA by 12 weeks. With more than 12 weeks, your patient is able to need a PPA, should evaluate for the cause, because PPA has a strong indication is only the GERD patient which has the PPA for little longer time. So when you have a normal GERD patient with normal symptoms like heartburn and chest pain, you try to stop the drug within 2 to 12 weeks. When patient had a endoscopy proven severe esophagitis, endoscopy proven Barrett esophagitis, patient need an indefinite duration. Even during that time, you have to try to stop or reduce the dose of the PPA, the more than 12 weeks. How to can reduce the PPA? You can reduce the PPA by demand, by decrease the dose of the PPA, depends upon the symptoms of the patient. So when the patient have more symptoms, you can use the high dose PPA. Once the symptoms is regress, you can reduce the dose. Initially, it is a 40 milligram BD of a routine any PPA, then come to 20 milligram BD. Then you can come to 10 milligram BD, or you can have a 20 milligram body, then 20 milligram every alternate days, and 20 milligram every 2 to 3 days. Then you can take whenever the patient feels like regurgitation or heartburn, and you can take single or either 1 or 2 day drugs. So the PPA should be de-prescribing from the list because it has an increased side effect. So when you are not able to de-prescribe like this, what we can do? Then you have to look for whether the patient had a coexisting H. pylori infection. So look for the H. pylori infection and do give a H. pylori eradication, and you stop the stop the infection, and you clear the symptoms, and you de-prescribe the PPA. So we always thought when you see your prescription list, you should always think whether patient need a PPA or not. So PPA, long-term PPA is only clearly 5 indications when the patient is having a GERD symptoms, severe GERD symptoms, and the patient taking a aspirin like NSAIDs, then have a duodenal ulcer, there is a risk of bleed, and patient had a positive H. pylori testing, and the patient is on long-term, patient need a long-term immunomodulator like rheumatoid arthritis like conditions, then you should take the PPA with the patient. Otherwise, the routine when you give a any NSAIDs, like when you have a prescribing diclofenac, routine prescription of PPA should be avoided at any cost. So whenever a patient is taking a PPA, like when a patient have a diabetes patient as a cardiovascular patient and arthritic patient, so all this patient should not have a PPA near than their prescription. Try to change over with the H2 blockers. So H2 blockers is equally effective with the PPA when you giving a prophylactic times. Like when the patient has a mild symptoms, gastritis symptoms, you can use the less potent drug like H2 blockers. Then once the patient didn't have any other symptoms, there is no need to PPA to combine the long-standing prescriptions. So how will you follow the patient? The PPA is a valuable drug. It's irreversible drugs in the prevention of certain disorders for the specific duration of the time. So when you giving the PPA should have a limited rules. Like we have to try to stop within 12 weeks. That's the only thing we need. And the last slide. So propranolol inhibitors often misused and overused, and the constipation, concurrent medication have told with metformin and diuretics. So we can start from this slide, sir. So PPA lessen the production of stomach acid and releases the pepsinogen into the pepsin and releases which need to absorption of the B12 from the dietary protein. So B12 absorption is ultimately decreased with the PPA, long-term PPA intake. So when the patient is complaints of like tiredness, fatigue, and anemia, always look for a B12 deficiency in our chronic patients. So B12 deficiencies will be potentiated by our long-term PPA intake. And next slide. And
can I move into next slide, madam?
Yeah, next slide. The recommendation of duration of therapy we already saw. This is the take-home message for everyone because GERD need a long-term PPA. So whenever you replace the PPA with H2 blocker 1, then you always administer the BPA 30 to 60 minutes before the meal time. And indefinite BPA maintenance only endoscopy proven grade C and grade D esophagitis. It is mild lax LES, mild grade A esophagitis, grade B esophagitis. Try to stop the drug within 2 to 12 weeks and should not have add any baclofen therapy without any objective evidence of GERD. And no need of, next slide, no need of any prokinetic agents without obvious evidence of gastroparesis. So whenever you combination of drug with PPI with Lesuride, PPI with prokinetic, there is no need for routine prescription. When you show the evidence of gastroparesis, you need to have a prokinetic agent. Otherwise, when the patient have only simple heartburn and chest pain or regurgitation, it is simple PPI is enough. We need to provide it with prokinetic combination only when the patient is having bloating or vomiting or postprandial fullness, like gastroparesis symptoms is there, then you add the prokinetic. And sucralfate, no sucralfate therapy for GID patient except during pregnancy, because already we have hypochloride, acid is very much suppressed, so no need for addition therapies, no need for a long term. And weight loss for overweight in obese patient, and avoiding meals within 2 to 3 of bedtimes, and you elevate the pillows, like these are mechanical symptoms, reduce the mechanical symptoms for the GID1. So anyway, we need to keep the mind, like you have to reduce the dose of the PPI, reduce the duration. So always do the other factor, like quiet smoke and quiet tobacco product, and avoidance of the trigger foods. Some people will have a trigger with onion, tomato, somebody with coconut, somebody with the chocolate. So the trigger fruits, foods, like it's avoiding the GID symptoms must be avoided. And prescribe the PPI if possible, and use the lowest dose of PPI for maintenance dose, and avoidance of routine addition of medical therapies. That is a very much important one. There is no indication for routine addition of any PPI, like take a paracetamol with rabiprazole, take a diclofenac with rabiprazole, take a etrocoxib with rabiprazole or pantazole. The routine prescription of PPI is not at all necessary. Only you have to prescribe with the indication. So next year. So whenever you think of PPI, you should try to remove from the prescription, because it has been like reduce the medical cost of the patient, and reduce the side effect of the patient. So next slide. So next slide. Next slide. Yeah, this is the recommendation from AGA. We already discussed in every point in detail, like de-prescription therapy and reduce the dose therapy and replace the H2 blocker. And always think of PPI, whether it is necessary or not. Next slide. So misuse of PPI, always I say, like when the prevention of, we thought like giving the PPI, we are preventing the gastritis. So patient didn't have any symptoms, but it is not like that. We are making a acid-less environmental stomach, which is not normal to the patient. So when we need acid for digestion, we need acid to prevent infection, we need acid to absorb some nutrition. So reducing acid is like we are creating a manual acid-less environment, will more prone for adverse effect. So you should not always misuse PPA. So prevention of gastroduodenal ulcer without any respect, and the patient is admitted, routine injection of antacid is not necessary. Only when the patient is having a risk of gastritis, like stress-induced ulcer, we need to give a antacid injection. So stress ulcer prophylaxis, non-ICU care is not necessary, and steroid therapy, when you give a steroid therapy and give a PPA, it is not necessary. And when you give an antiplatelet drug and anticoagulant treatment need a combined with the PPA, it is not necessary. And over treatment of functional dysphasia, when the patient has anxiety, when the patient has been bloating, when the patient has been burping, when the patient is releasing the gas excessively, there is no need to add PPA. So give a simple Rantac and reassurance is enough with the functional dyspepsia, or the patient is having any underlying psychiatric symptom should be identified and treated. So when you are using the PPA, always think whether the indication is correct, and whether we are using the PPA with the correct dose and duration and the correct indication. That is the only take-home message I just want to give to the person who are attending this meeting to rethink of PPI right before you writing in your prescription whether it is needed or not, because all the old age patients with like diabetes, hypertension, heart patient, stroke patient, everyone has a PPI drug in addition without need any indication. So I thank IMA and IMA members. Sorry for the difficulty in sharing the slide with my system, and sorry for the short
Absolutely no issues, ma'am.
between. And I thank everyone to patiently listen this speech, and I thank again our IMA secretary and IMA Tamil Nadu for giving me the opportunity and talk about the PPA with the doctors people. So thanks everyone. Thank you.
Thank you, madam. Over to Dr. Shafiq sir for your opinion, sir.
So good evening, everyone. It's a nice presentation from Dr. Radha. She was my colleague in DM in Chennai. And in PPA abuse, there's actually three terms is that. One is PPA misuse, the another is PPA overuse, and PPA abuse. You should know to differentiate between these three terms. What is PPA overuse is when you give a dose of PPA and in a more than a separated dose. Whereas misuse is you are giving PPA in conditions other than the indicated one. Whereas PPA abuse, this is the most dangerous condition. So we are taking like what we are discussing, like taking PPA for a very long period, irrespective of the cause, without knowing the etiology. So this has to be curtailed. Nowadays, this PPA is available everywhere, and most of our population knows about this pantoprazole, rabiprazole, all those drugs. So polypharmacy, whenever you go to a medical shop, tell about heartburn or bloatness, any pharmacist or medical people will give. So everyone will, when you come to your gastroenterologist, already they would have taken PPA for more than 3 weeks or 4 weeks. Then only they will come and consult your doctor. So the best time to educate not only the patients but also the general colleagues about the abuse of PPA, and the right time to de-prescribe the PPA. And now newer drugs have come like PCAPs, like we call as vonoprazan in the market. So that these are some of the drugs which can be tried instead of using PPA for a longer period of time. That is my view, sir. Thank you.
The next topic, we are running short of time. So the next topic is on polypharmacy on the rise, where we are heading. The speaker is Dr. Pothiraj sir, President Sankarangoil IMA, and the moderator will be Dr. Nalamuthu Swami sir, Secretary Sankarangoil IMA, and the expert comment will be from Dr. Subramaniam sir, President IMA Tirunelveli branch. Sir, can I request Dr. Nalamuthu sir to introduce Dr. Pothiraj sir?
Good evening, everybody. I am Dr. Nalamsami from Shankarangoil, and there is no need to introduce our speaker, Dr. Pothiraju. He is a senior physician in our town, and he finished his MBBS at Tirunelveli, and he finished his MD in General Medicine at Madurai Medical College, and now he is practicing at Shankarangoil. Multi-speciality hospital, Ravi Hospital, is run by him, and he is going to speak about the polypharmacy, now the biggest problem in our practice, everyday problem. And over to Dr. Pothiraj.
Bus. I to thank the organizers of this meet for giving me this opportunity. The given topic is polypharmacies on the rise. The medications may be appropriate or inappropriate. The use of more medications than are medically necessary is called that they are not indicated, or medicines are not effective, or therapeutic duplication. These are all called inappropriate. And Ramesh. So the prevalence of polypharmacy is about 35% as far as India is concerned. More common in elderly individuals of more than 65 years. The prevalence is actually increasing. 30%, 39% of the older Americans take 5 or more medications. A recent review in the literature shows ambulatory care patients, that is 37% of the males and 36% of the female community dwelling adults have 5 or more medications. 43% take OTC products and 54% of the individuals take dietary supplements. And the hospital data shows at discharge, almost 41% of the patients were on 5 to 8 medications. 32% of the individuals were on more than 9 medications. And more than 50% of the patients took 1 or more unnecessary prescription drugs. And again, nursing home review shows more than 40% of the individuals were prescribed more than 90 medications. What are the contributing factors for polypharmacy? As the population gets older, increasing life expectancy is one of the most contributing factor for polypharmacy. Increasing prevalence of multiple comorbid conditions and wider availability of the effective drugs for various clinical scenarios, and the prescribing cascade, that is when an adverse drug effect is misinterpreted and treated with a new drug, and this leads to prescription of more medications. And the availability of plethora of treatment guidelines which recommend multiple medications for a single condition. They are mainly focused on single condition drugs as well as hypoglycemic medications. Polypharmacy disease interactions. Polypharmacy invariably results in medication non-adherence also, reduced functional capacity of the individual at large, so like functional decline, cognitive impairment, trip and pulse resulting in fractures, urinary incontinence, and malnutrition. So, is management of polypharmacy. Certain criteria, potentially inappropriate medicine criteria. This criteria is based on trial evidence, based on expert opinion, consensus statements. Like other criteria is implicit, potentially inappropriate medicine criteria. This is mainly based on patient-centered and sensitive for IMU. This is a time-consuming and dependent on expertise. Another one is medication appropriateness index and this prescribing algorithms. These criteria was developed by American Geriatric Society in the year 2019. Since it has been updated periodically, the recent update is in 2023, I see. What does it contain? Mainly, it consists of a series of medications to avoid related to common problems to particular medical conditions. Several of the medications are specific to the USA. There are more than 7 tables are available. Each table contains different tool for dealing with polypharmacy, or mainly for introductory purpose. Table 2 contains potentially inappropriate medication is in older adults. And table 3 contains names and all these things. These are available in the net. Easily you can assess. What is it? There are some key principles for optimal use of these criteria. One is medications are inappropriate, and we have to read the guidance to understand the caveated guidance. Understand why medications are included on the list. There's better identify the potentially inappropriate medicines and offer safer alternatives to non-pharmacological strategies, including reducing polypharmacy. This criteria don't apply. Suppose if you use, if you want to use antihistamines, generally first generation antihistamines contain they are more anticholinergic side effects. Among first generation antihistamines, brompheniramine, chlorpheniramine, clemastine, diphenhydramine, doxylamine, these are all highly toxic general geriatric population. There are some alternatives. Second generation antihistamines. Of these second generation antihistamines, cetirizine, fexofenol, loratadine. Fexofenol is the least toxic drug. Other alternatives are intranasal steroids, beclomethasone, and fluticasone for nasal allergies can be used instead of first generation antihistamines. The other important tool to overcome polypharmacy is START tool. START is nothing but a screening tool of older people's potentially inappropriate prescriptions. START tool is screening tool to alert doctors to write treatments. This START tool contains a series of rules and suggestions related to high-yield problems in prescribing for older people, both in terms of reducing medication burden and adding in potentially beneficial START therapy. This is an example START criteria. Among cardiovascular system drugs, digoxin, for long-term use, more than 125 microgram per day in patients with renal dysfunction is only with no signs of heart failure. There are other alternatives are just compressive stockings. It's better to avoid loop diuretic for simple pedal edema. And always better to avoid thiazide diuretic when the hyperuricemia and gout because of the precipitation of or worsening of the gout symptoms. And it's better to avoid non-cardioselective beta blockers with COPD for the fear of increased bronchospasm, worsening of symptoms, as well as diltiazem or verapamil. It's better to avoid in New York Heart Association classification more than 3 or 4 failure will happen. Calcium channel blocker better to avoid in chronically constipated patients, may exacerbate constipation. What another important drug in the therapeutic armamentarium of cardiovascular diseases, really atrial fibrillation. For first uncomplicated DVT of more than 6 months, it's better to avoid. For first uncomplicated pulmonary embolism, duration of more than 12 months, warfarin therapy is unacceptable. Among central nervous system and psychiatric drugs, tricyclic antidepressants with the dementia, the risk of worsening cognitive impairment is more in tricyclic antidepressants. And the SSRIs are known to produce severe hyponatremia. So it's better to avoid in elderly individuals. And there is just now, Dr. Tava explained explicitly the proton pumps and NSAIDs with moderate severe hypertension or heart failure. It's better to avoid NSAIDs in elderly individuals. And this is the example for START criteria. Again, warfarin is recommended in chronic atrial fibrillation, aspirin in chronic atrial fibrillation, and warfarin is contraindicated. And antihypertensive therapy, systolic blood pressure is more than 160 millimeters of mercury, always institute antihypertensive therapy, but recent guidelines have changed. And use of statins, when there is history of coronary, cerebral, or peripheral arterial disease, when the patient is functionally independent for activities of daily living and life is more than 5 years, statin therapy is indicated. And use of ACE inhibitors with the chronic heart failure following acute malabsorption. These are all situations where ACE inhibitors are definitely indicated. And repeat markers with the chronic stable angina, definitely, and the bypass network. The calcium and vitamin D supplements, osteoporosis, because of the fragility factor as well as acute muscle kyphosis, is always indicated. Antiplatelet agents in the use of diabetes mellitus with major cardiovascular risk factors also indicated. Another tool to manage polypharmacy is medication appropriateness index. The content of this questionnaire is aspect of prescribing for the individual indication, that is effectiveness, dose and corrective directions, practical directions, drug and drug disease interactions, duplication and duration of therapy. These are things we can, by using appropriate this MA, we can ask, is there really need for pharmacotherapy in this particular patient? Is this the optimum medicine for the specific clinical diagnosis in this patient? Will this medicine introduce unnecessary duplication the existing medicines in this patient? Is the dosage correct? Is the formulation suitable for this patient? Is the duration of therapy suitable for a particular patient? Is this medicine likely to interact with the existing medication? Is the medicine likely to affect or to be affected by current disease? Are these directions for use correct and feasible for this patient? These are all things we have to answer when you prescribe, especially in elderly individuals. Another tool to address polypharmacy is deprescribing. This is a process of withdrawal of an inappropriate medication, usually supervised by healthcare professionals. Our goal is to manage polypharmacy and improve outcomes in elderly individuals. This is focused on risk-benefit assessment of continuous medication use. Generally, 90% of the older people in a variety of settings would like to stop medications if their doctor or attending healthcare professional said it was possible to stop this drug. And what are the barriers for employing all these criteria for polypharmacy? Limited consultation and follow-up time with the consultants, fears about recurrence of symptoms or worsening of the original condition for which the medicines are advised, beliefs about medication use and previous experience, and because of contradicting specialist recommendations. This is nicely depicted Deprescrbing Algorithm, which is time-consuming. It's available in the net. We can easily access. And again, another tool for polypharmacy management is good palliative geriatric practice, where this algorithm-based approach. So, what are the solutions to polypharmacy? Review of the medications meticulously. Always anticipate adverse drug events. Avoid errors in prescribing carefully. Give verbal and written instructions to the caretaker as well as patients. Simplify the regimen. Understand the obstacles, that is, physical deformity of the individual patient, and always enlist family, nursing, as well as care providers. Ensure that there is good follow-up. Always better to remember prescribing cascade. It is a drug ordered to treat mistakenly the adverse drug reaction of another drug. The clinical symptom in an elderly person should be avoided potential area until proven otherwise. Many geriatric syndromes can occur as a symptom. And finally, the take-home message is polypharmacy is a reality of prescribing when patients have multiple comorbid conditions. We must all anticipate and guard against the potential complications of polypharmacy. Optimal prescribing is the key. Thank you for the patient hearing. Thank you once again.
Thank you, sir. Thank you, sir. May I request Dr. Subramaniam, sir, for his closing words?
Thank you, Bhotiraj sir and Alamuthusamy sir. So it's a really concise presentation about the medications. The basic thing on this is, as it's all nowadays specialty-based practice. Patients have multi-organ disease, so they tend to see different consultants and getting different prescriptions. As a specialty consultant, we need to check about the other consultant prescription before we write. The one common drug I find is more about the PPI. Different consultants write PPI in different prescription, different ways. So that is one multiple prescriptions for the same drug. The other one is the calcium channel blockers. Also, quite a few prescriptions I've seen. And just a second, somebody is looking at the camera now. But Sir has explained in detail. We need to be very careful with the legal member group is always looking around the corner. We are always watched with the legal luminaries because of risk factors with the polypharmacy and duplications of drugs. We need to be very cautious to check with the other consultant prescription before we write ours. So, some people, the liver disease, a renal disease, we cannot get them back. So that's a concern to remember. And thanks, IMA Sangaran President, Secretary, and the members for taking this session up for this.
Thank you, sir. Thank you, sir. For short of time, we'll move on to the next topic. The next topic is on subfertility, whether it is a new normal. Speaker is Dr. Archana, who is a fertility specialist from Thoothukudi. Moderator of the topic will be Dr. Pungodai Madam, President, Thoothukudi IMA, and expert comment will be from Dr. Doris. Over to you, madam. Over to you, Dr. Archana, madam. May I request Dr. Pungodai, madam, to kindly introduce Dr. Archana, madam.
Yes, sir. Good evening to all. Yeah, I am happy to be moderator for this session. The topic is subfertility, new normal. What is new normal? After a crisis, there is a dramatic transformations in economic, cultural, and social aspects, leading to individual and collective perceptions. So this recent time is like instant yoga. Youngsters are expecting the results immediately. So there are decade by decade, there are so many changes in treatment of infertility. Let us hear to Dr. Archana. She is well known to me. She is running a infertility center, Omega Fertility Center in Thoothukudi town. And she is very active in FOXI activities and as well as IMA activities. So the previous slide, sir. Okay, let us hear from the recent trend. Yeah.
Can you see, ma'am?
He is a fertility specialist and the director, Omega Fertility Center, Sundaram Aruldas Hospital, Tuticorin. She is vice president of Tuticorin Obstetrics and Gynec Society. She has been awarded ISAF Rising Star Award TAPCon, and she is member in ISHAR, ISAR, IFS, FOXI, and IAGE. Speaker at various national and state conferences. She has conducted many CMEs and organized workshops and camps in Tuticorin FOXI. She has conducted awareness program on infertility, violence against women, high-risk pregnancy, women's health, cancer screening, adolescent health. Okay, Archana, we are eager to hear from you about the recent trend. Over to you, Archana.
Thank you, Madam, for the kind introduction. Good evening to all. I would first of all like to thank IMA Tirunelveli for giving me this opportunity. And now I'll be talking to you about subfertility. Has it become the new normal? Of course, the incidence of fertility issues is going up and is becoming a pandemic, something like diabetes. And I'll just be listing, it is a wide subject. I'll be listing the causes which have led to this new normal in the males and in the females. So subfertility, as I already mentioned, is becoming a global problem. And according to WHO, the incidence is about 10 to 15% in the married couples. So there's a little difference between subfertility and infertility. Subfertility is basically reduced fertility that results in a longer than average time to conceive. That's what we mean by subfertility. Whereas infertility is inability to conceive after 1 year of unprotected intercourse. But although there's a subtle difference between the two, both these terms are usually used interchangeably. And just like the global scenario, Indians also have a similar incidence of up to 15%. The causes in the Indians is because of rapid urbanization, late age of childbearing, more stressful lifestyle, obesity, their habits of smoking, alcohol coming in very commonly, and the presence of comorbid illness. So the main consolation in this aspect is that ART treatments have also, that is treatments for these subfertile problems have also increased in leaps and bounds. And it has now been 42 years since the birth of Louis Brown, the first baby that was born through IVF. And now with the advancement in IVF and the introduction of ICSI, this has further improved the success rates in subfertile patients. So going a little into the Indian scenario, India is a mixed bag. We have both groups of women who get married early and also women who delay their marriage and childbearing because they want to settle in their professional life. The one thing that women are forgetting is that their biological clock, that is their natural age, is not going to wait. It is going to move on. And the only consolation again is that we're not lagging behind, as I already mentioned, in our ART treatments. And India approximately performs 1 lakh cycles of IVF per year. And this is not only performed in the metros, the real metros. You can see it's almost equal where the cycles are being performed. That extent of fertility centers we do have equally both in the main metros as well as in the peripheral areas, peripheral cities. So going to the causes, the males and females are equally affected. So this is one thing we should always bear in mind. And whenever we want to take up the issue of subfertility and its management, it's important we see the couple, both the male and the female partner, because the incidence is about 30% in the female, 30% in the male. And it could, and you can have combined causes of male and female causes combined together in about 20%, and in another 20% the causes are unexplained. So I'll be discussing the female and the male factors separately. The common female causes of infertility include endocrine disturbances like the thyroid problems, endometriosis, ovulatory failure, tubal damage, urogenital infections, and anomalies in the uterus. The key factors which have caused an increase in female infertility are the female age, the BMI, lifestyle factors, ovulation problems, commonly the polycystic ovarian syndrome, tubal factors, fibroids, and other uterine anomalies, endometriosis, and hormonal imbalances. So let's look at each of them. If you take age, it is the biggest and most important factor. As I said, age keeps moving and there's no way we can stop it. And actually, studies have shown that 80% of the couples usually conceive within 1 year if the woman is under 35 years of age. So which means the cutoff age is 35. When the woman reaches 35, it should ring a bell in our mind. There is a substantial decline in fertility beyond 35 years. And this aspect should be very keenly kept in mind for Indian women, because studies have shown that in Indian women, their ovarian reserve, that is a number of eggs which are able to give birth to give rise to pregnancy and a live birth baby, is 6 to 7 years earlier in Indian women compared to the Western woman. So if a woman is 42 years in the Western world, the number of eggs and her capacity to conceive and give birth to a baby is equal to a 35-year-old Indian woman. So that's the age impact we have in the Asian population. So it's important that that women, when they reach 35 years, they should start keeping their profession aside and think of going into childbearing. And also with advanced age, there's increased incidence of miscarriages. So if you see this graph here, you can see the fertility levels falling substantially as the age advances, and the spontaneous miscarriage rates also going up as age advances. Let's go to the BMI. Of course, the normal BMI that we consider is 18 to 25. But in Indian women, the normal BMI to be taken is 23. So we do consider beyond 25 as obese, and it should, any woman beyond 25 should be advised to go ahead with a weight loss. And weight loss is the cornerstone to achieve pregnancy and childbirth. Hence, it is important to emphasize on weight loss in all infertile patients. And studies have shown that even 5% weight loss improves the fertility outcomes to a great extent. It can cause, it can regularize the cycles, it can result in spontaneous ovulations, spontaneous pregnancy, and live birth rates. And whenever the woman's BMI is more than 35, it is difficult to even treat them and get them pregnant, because all results are halved when the woman's BMI is at this level. Diet plays an important role in the treatment of fertility. Fertility treatment is not just drugs. Diet plays an important role, and what's the type of diet we want to advise them is a low carbohydrate diet, rich in proteins with balanced fats. And it should be started from day one. Should be explained to them, to the couple from the first day of their visit. And the diet should contain a good amount of antioxidants. I mean, we can supplement them with antioxidants such as vitamin E and C. And an important part of the fertility treatment is supplementing with 5 milligrams of folic acid. And we continue all these drugs until the woman becomes pregnant. So a little more into the diet, what studies recommend is that they should follow general healthy eating principles. It's not that for a short time I've lost 5% weight, I stop it. It's not that. Across their life course, they have to continue their healthy diet. And if they want to achieve a weight loss, there should be a calorie deficit of 500 to extra calorie deficit of 500 to 750 calories per day. And women who smoke and alcohol, when they go on to trying for a pregnancy, it is better they avoid it. And coming to the exercise, the recommended exercise is a minimum of 150 minutes per week of moderate intensity physical activity, or 75 minutes per week of vigorous intensity exercise on two non-consecutive days a week. So women who have a BMI beyond 35 have tried weight loss or are not keen on really going ahead with difficult diets and weight loss exercises can go in for bariatric surgery. Bariatric surgery is now being performed for many of the infertility patients. Sometimes when the age is more, we want to go for a treatment earlier. The procedures performed are sleeve gastrectomy and gastric bypass surgery. These procedures do cause a sustained and significant weight loss of 40 to 50 kgs. The only thing following a bariatric surgery is that we should avoid trying for pregnancy or going ahead with treatment for the first year. Next, going to ovulatory problems, of which the most important is PCOS. I think the most important cause, which is really on the limelight, is the polycystic ovarian syndrome as the commonest cause of all infertile problems. The prevalence is about 5 to 10% of the women of reproductive age. And the key factor, the key pathology in this polycystic ovarian syndrome is insulin resistance. So what is the clinical pathophysiology? If you see here, it could be either genetically or predisposed, or it could be due to lifestyle factors. And in 80 to 90% of the women, it's due to their lifestyle. The increased the food habits of eating more of unhealthy diet and less physical activity are the main contributing factors to lifestyle, and this starts in the adolescent age group. So both these genetic factors and the lifestyle pattern can result in hormonal changes, and the important hormonal changes are hyperandrogenemia and hyperinsulinemia. These hormonal changes bring about various problems which are further exacerbated if the woman is obese. So they act on the ovarian follicles, result in anovulation. This anovulation can result in menstrual disturbances leading on to subfertility. The hyperandrogenemia can also result in hirsutism and acne in the female. And the hyperinsulinemia can lead on to diabetes, other metabolic syndromes, and also pose a cardiovascular risk to the woman. All these causing psychosocial issues leading on to depression, anxiety, and loss of self-esteem. So the diagnosis of PCOS, it is always what we have studied in our undergraduate days. From the undergraduate dates, it's the Rotterdam criteria, and it's still followed till date, of which 2 out of these 3 features should be present, either an oligo-ovulation or an anovulation, or the clinic or presence of clinical or biochemical hyperandrogenemia, or a polycystic appearance on ultrasound. So what do we mean by polycystic ovarian picture on ultrasound? Is the presence of more than 12 follicles in each ovary, or an ovarian volume of more than 10 centimeter cube. So if any 2 of these 3 features are present, we can diagnose PCOS. And there are 4 subtypes, A, B, C, and D, according to the combination of which features are present. So before we diagnose PCOS, we should rule out other causes of anovulation, which could be a hypothyroidism, hyperprolactinemia, or a congenital adrenal hyperplasia. One important hormone which is now being recommended for diagnosing PCOS is AMH, but still has not come into the diagnostic criteria, but it is a very useful hormone level. We call it the anti-Mullerian hormone, and these levels are generally, are increased in women with PCOS, and it helps really in the diagnosis of PCOS, although it has not yet come into the diagnostic criteria. It's still under studies. Obesity, acne, and insulin resistance, although they are present in most women with PCOS, also they are not included in the diagnostic criteria. And if the woman has obesity with acanthosis, it strongly points to polycystic ovarian syndrome. So the management is, first line is always the lifestyle modification. And in the drugs, the first line of treatment is ovulation induction with ovulation-inducing agents such as clomiphene citrate or letrozole, along with insulin sensitizers such as metformin. The second line of therapy is to use gonadotropins such as FSH or HMG. Laparoscopic ovarian drilling, the common term of PCO drilling, which was initially thought as a first-line management for PCOS, is now definitely not the first. You can see it's in the second line and also towards the end. It is reserved for only with women who have really resistant PCOS, who don't ovulate with either drugs or injections. And when it is done, it will be helpful only in lean PCOS. An obese woman with PCOS, even if she undergoes laparoscopic ovarian drilling, she will only lose her ovarian reserve, but she will not ovulate. So it is very important for whom you really go ahead with this procedure. And the third line is to go ahead with advanced ART procedures such as an IVF or an ICSI. So once we say PCOS, it is closely related to diabetes. And we now see that male and female partners commonly present with diabetes, as diabetic has also become a pandemic. So what are the problems this diabetes can cause in the females? It can increase the incidence of genitourinary infections, it can cause menstrual disturbances, anovulation. It can result in autoimmune reactions against the sperm and egg, resulting in increased miscarriage rates. And of course, PCOS, diabetes, obesity, or are triple threats for any kind of infertility treatments. And in the males also, diabetes can affect the sexual dysfunction. Most diabetics, they have problems of erection and ejaculation. It can cause abnormal sperm parameters, and sperm DNA damage is also common in diabetics. Next, going to endometriosis. This is also becoming a common prevalent problem. We encounter it quite commonly. Whenever we have a woman with unexplained infertility, if they are worked up a little deeper, we find that they have endometriosis. And it has been found that among the infertile women, the incidence is quite high, about 25 to 50%. And the severity of the disease and how we go about managing it depends on the stage and location. So actually, there are 4 grades: the mild, moderate, the mild, minimal, mild, moderate, and severe. And usually the medical management, we have a lot of medical managements, the use of hormones, whether it's oral contraceptive pills, the progesterones, or the GnRH analogs, all these are used in endometriosis only for pain relief. They are not for providing treatment for infertility. So generally, if the woman has a minimal or mild disease, we can just go ahead with infertility treatment without planning for a surgery or without actually giving her any kind of a medical management. But if the woman has a moderate to severe disease, it is important that we go ahead with the surgery. And whenever we plan surgery for an endometriosis patient, it's always important that we go ahead with a laparoscopic surgery rather than open surgery to prevent the further spread. And it should be done by a skillful laparoscopic surgeon because it is very important that the damage to the tissues is very minimal. And always it is for best results, it's important that we follow it up with an advanced ART treatment like an IVF. Okay, going to the fibroids. Fibroids are also quite common these days, and the management of infertility with fibroids depends upon the type of fibroid and its location. You have basically three types: the subserosal, which is just outside the uterine cavity; the intramural, which is inside the myometrium; and the subserosal, which just projects into the cavity, uterine cavity. So the patients who really require a myomectomy, that is removal of the fibroids, are those who have this submucous fibroids. So they can be hysteroscopically resected, and intramural fibroids, that is fibroids in the myometrium, which are bigger in size, more than 4 centimeters in size. So these are the only patients who really require a myomectomy before you go ahead with fertility treatments. But those women who have subserous fibroids or fibroids in the myometrium that are less than 4 centimeters, really do not require any intervention. We can go ahead with our fertility treatments for them. Next, going to the tubal factors. The commonest tubal cause of infertility is the tuberculous salpingitis. And if it is confirmed, the woman should be treated with anti-tuberculous drugs for 6 to 9 months, ATT for 6 to 9 months. And those patients, women who have had tuberculous salpingitis, it is better to advise them to go ahead with an IVF, because even though sometimes the tubes are blocked following the salpingitis, following the infection, but sometimes you do have patent tubes, but the tubes are not functionally normal. Hence, these women will require IVF. And if you have a hydrosalpinx, that the fluid is that the tubes are filled with the infected fluid, it's better to go ahead with the removal of the tube before we go ahead with our IVF. And another problem encountered with the tubes is the cornual block. This is the block at the uterotubal junction. This is one type of tubal problem which we can manage, which we can cure, which we can handle. We can hysteroscopically cannulate the tube, recanalize it, and following this procedure, the woman can try for a natural pregnancy. So with this, we move on to male infertility. So these are the problems we have in the male sexual dysfunctions, abnormal semen parameters like low volume, low counts, reduced motility, reduced vitality, increased DNA fragmentation, and poor fertilization potentials. So when we say abnormal problems, we should know what are the normal semen parameters, the normal sperm values that we are looking at. So this is according to the WHO criteria that we follow. So until now, it was the 5th edition that we were following. Recently, since 2021, we're following the 6th edition, in which the normal volume of semen should be 1.4 ml, and the total sperm concentration should be 16 million per ml, with 42% total motility. And what is more important is the progressive motility, which should be 30%, with vitality of 54%, and the morphology should be minimum of 4%. So this is the WHO criteria we currently follow. So the causes for increase in male infertility are also just like the woman. You have multiple factors: the age, the BMI, the nutrition, occupation, smoking, alcohol, and the use of drugs, sports, stress, which could be psychological, oxidative stress, hormones, infections, and genetic factors. So we are always concerned about the maternal age. We're always talking about the advanced maternal age, but the advanced paternal age is also important. Initially, it was thought that because there is fresh, the spermatogenesis occurs every 90 days, and there's a fresh sperm production every 90 days, men can produce good sperms, which can give a pregnancy until up to any age. But that's not true. Studies have now shown that after 35, or more accurately after 38, the reproductive potential of the man also drops sharply, because as the man ages also, there is increased amount of DNA fragmentation in the sperms, which affects the fertilization potential and also can lead on to infertility. So you can see here the sperm DNA fragmentation, which is about 10% when the man is around 20 years, gradually increases to 25% when he's 40, and further increases as age further advances. Hence, both the partners should plan their pregnancy at the right. So obesity is another important problem, and obese men have all types of problems, sexual dysfunctions, abnormal semen parameters, and also this one important thing is male obesity. When they have male obesity, it affects the sperm parameters as well as the embryo. It reduces the potential and increases the abortion rates. It's not only the woman's problems in the egg, it's also problems in the male, and in the offspring also it can result in subfertility. And diet and nutrition, as similar to the women, they have to follow it. And men who work in high temperatures, exposure to heavy metals, pesticides, have all chance of having abnormal semen parameters. And similarly with sports, and radiation is one important thing. The radiation from mobile phone usage has found to increase the scrotal temperature, and hence whenever we are treating patients with infertility, we advise them to not use mobile phones, to reduce it to a minimum. Okay, and next, coming to stress. Stress has increased a lot among men, and this really affects the sperm DNA fragmentation to a great extent. So we can overcome male problems by lifestyle modifications, antioxidants, and one of the most important advances is the micromanipulation, which is the ICSI procedure for treating severe male problems. So there are various treatments. I just thought I'd put a word about treatments. That one is the IUI, which is the simple and first step. Here we just process the semen, and if you're actually want of time, I'll just explain the ICSI procedure, which is the most important, more advanced method, which has the best success rate, and which we are doing it in day-to-day to treat most of the infertile patients with a success rate of 60 to 70%. So I just have a short video of that. I'll just finish with that. So what the first step in the ICSI IVF procedure is to stimulate the woman's ovaries after initially evaluating her with gonadotrophins. So this is the ovary, which, So this is the ovary with the stimulated eggs, stimulated ovarian follicles. And under ultrasound guidance, we use a oocyte pickup needle to retrieve the oocytes. You can see here the needle which is inside the thing, and we collect the oocytes along with the follicular fluid into test tubes, which are placed in test tube warmers. And the follicular fluid containing the oocytes, each follicle contains one oocyte and is collected in test tube warmers. And once all the oocytes have been aspirated, the oocytes are handed over to the embryologist in the IVF lab. And in the IVF lab, they examine the follicular fluid, separate the oocytes. The oocytes are not present separately. They're present along with the oocyte cumulus complex. And so this is the oocyte cumulus complex. Sorry, I'm very sorry. So this is the oocyte in the center with the cumulus complex, and then you denude the oocytes from the cumulus complex and separate only the oocytes. And once the oocytes are denuded, they're kept aside in the incubators, and the semen sample of the husband is collected, and the sperms are checked in the ICSI microscope, and the best sperms are selected, and they are first immobilized, and then they are aspirated into the injection pipette. I'm really sorry for that. They are aspirated into the injection pipette, and the oocyte is held with the holding pipette, and the sperm is injected into the oocyte. Once healthy sperm is injected into each oocyte. Following this, it's kept in the incubators for fertilization to occur, and on the next day, we check for fertilization, and usually you see the two pronuclei. That's the first thing to show that fertilization has occurred. That is, on day 1, it becomes a 2-cell stage. Day 2, it becomes a 4-cell. This is the 2 pronuclei, and the 2-cell stage. This is day 3 when you have 8 cells, and we let the embryos grow up to the 5th day. This is the day 5 embryo, in which you have the inner cell mass with the blastocyst cavity. This is called a blastocyst, the beautiful embryo, which has the highest implantation potential. And this is aspirated into the embryo transfer catheter. And here you can see the blastocyst in the embryo transfer catheter. And this is beautifully transferred into the endometrium of the uterine cavity, which is adequately prepared under ultrasound guidance. So a series, this is the miracle of IVF. Thank you so much for the lovely opportunity given to me. The only concluding remark that I would like to say is that though infertility is becoming really common, we have solutions to all problems. Thank you.
Thank you, madam. Thank you. May I request Dr. Doris, madam, to give her closing comments?
Good evening, dear all. Thank you, organizers. Thank you, Dr. Rachna, for this overall coverage of subfertility. Nice highlights from your side. In spite of tremendous advances in the field of infertility, there is also increasing infertility, and both male and female contribute equally. We cannot deny that. Even though the talk was overall more on the female side, because we concentrate on treating the female more because she has to give birth to the baby. The contribution to infertility is equally from both and female side, and in rice it is becoming almost new normal because major thing is this is the price we have to pay for the modernization, the lifestyle, and most of the products we use, environmental changes or all embryotoxic even, those all contribute to the rise in infertility. And the things you said, endometriosis, fibroids, this we were not, obesity which leads to the subovulation, all those things we were not encountering some 30 years back like this enormously. But thanks to the advances in the infertility area, in the field of infertility, we are treating this thanks to people like Archana. And what I feel is prevention is better than cure. In this field of infertility also, we have to focus on prevention, right from there should be a global strategy of research for studies with respect to the products we are using, which are embryotoxic. Like that changes should come from the root level, which will help in the long run to reduce the subfertility, which is becoming a pandemic. Thank you.
Thank you, madam. We'll move on to the next topic, monkeypox rising in India. The speaker is Dr. Santhanam. He has graduated his MBBS and MD from Madurai Medical College. He's a young infectious disease specialist who recently completed his infectious disease DM from AIMS Jodhpur. The expert comment for this talk will be from Dr. Napoleon, sir, who is a retired HOD and a professor of microbiology at Tirunelveli Medical College. Over to you, Dr. Santhanam, sir.
Yeah,
Dr. Santhanam, sir.
Yes, sir. I'm audible, sir.
Yeah, yes, you are audible. You can go ahead, sir.
Yes, sir. Thank you. Thanks to IMA and outside again, I am thanks to my rheumatologist Subramaniam, sir. I will go with the monkeypox. It's more awareness need to create. I think whether we are going to land up in pandemic or not, but we need to know about monkeypox. It same like other COVID or not. Let's see what I will give few seconds for monkeypox case really rising in India or not. This was our question, yes or no. The question is, they started cases, suspected cases, they went to diagnosis, now coming positive, complete on isolation. Whether we'll see suboptimal cases, always I were the phenomenon, whether it's there or not. That one we need to show. How monkeypox will be started and everything we will see. Monkeypox is a zoonotic disease, same like pox, smallpox, chickenpox, it will be one of pox virus. How they are origin from West Africa or Congo Basin in 1958, they started. These are all the area distributions are so this one very old slide, 2022 according to that. For 2022 itself, there is India case reported. Now, the reservoir is not human mainly. Human is secondary. The primarily from animals, several animals, mammals, non-human primates, monkeys, dogs, whatever you want, you read. Humans are incidental cause. It's not primary cause. How they acquired from animals, let's see. It's not from nasal secretion. It will be either scratch, contacts, either eating meat or something else away from animals, not primarily respiratory droplets. But human, it will be predominantly respiratory droplets, also from other contacts also, it will be possible. Either endemic or now started pandemic, it will be same like COVID precaution we are going to do right away. Whether biohazard 2 according to the WHO. Now labs are need for biosafety level 3. Only it's available in NIV Pune in India. This is I told already that animals primarily by directly contact, either anyway. Respiratory is secondary from animals, but human is primarily respiratory droplets inhalation, but others also possible. This according to the old studies from 2022, there is few cases reported. There is sexual contact also predominantly in worldwide. There is reported mainly predominantly homosexual individuals. Even HIV positive individuals also there is chances high. There is chances of STI co-infections also high. Co-infection rate same like HIV. There is STI sexually transmitted infections are common in these patients. Incubation period approximately 6 to 13 days, but the range will be variable. Period of communicability the same like the chicken box will take few days before the rash started until the scab healed, that will be infectivity chances high. There is most common symptom of monkeypox, which one is whether flu-like illness, cutaneous manifestation, or other something like COVID, pneumonia, possible let's see. The suspected cases means always there is started with unexplained rashes, some skin lesion, some form of skin lesion with some symptoms, either flu-like illness. Simply put it is flu-like illness, some skin lesion, either whichever is possible. No need to worry. These suspected cases. Sorry for the interface. Probable case means there is a epidemiologically linked whether we need to do one point. Another thing is sexual partners that will also need. Otherwise, there is some IgM will be positive as probable case. Suppose you are telling like confirmed cases means I think slides are not more. Probable cases. Confirmed case means always PCR need to positive. PCR need to positive confirmed cases. The prodromal symptoms always like flu-like illness, either whichever is lymph node or fever, myalgia, sore throat, everything possible. The skin lesions don't much more thing you need to concentrate. It's like a chicken box. It will start like macule, papule, vesicle, pustule, like that. But either rashes also possible. Whichever skin lesion you need to consider. Travel history you need to confirm. How will differentiate with the other monkeypox, chicken box, or some other small box like that way? You see whether centrifugal spread or centripetal spread or like the way. Centrifugal means it will be start from the face and then extended to the body and then extended to the part from trunks to periphery. Like the way limbs it will be centrifugal. Centripetal means it will be start from chest and then spread to entire body, like the way. It will be opposite, like the way. Centripetal chickenpox forms and souls are rare in theoretically, but we are seeing cases of chickenpox with forms and souls. There's any point of parents coming consider monkeypox with the travel history, so you need to consider. Always also the consider other form of DD also, the hand, foot, mouth syndrome or something syphilis. Syphilis also rising so much cases in our places. So we need to alarm. Slides are struggling a little bit. Okay. Different form of skin lesions are there. The complication not due to monkeypox, same like HIV patient, it will be complication due to the secondary infection, either bronchopneumonia, skin infection, septicemia. That way patient will be getting mortality. Suppose you ask like COVID, which is better sample for monkeypox, it's not sputum or ball or even blood. It will be always go with skin lesion. Which form of skin lesion you need to select? We always, I told like biosafety level 3. You need to wear like PPE, same like COVID pattern. So you need to consider. You go very deeper to the skin lesion and you take from underlying part of skin lesion, better you would take comparatively. If at all skin lesion not possible, you go with other form like blood or urinary sample, you go with that. Always go with skin lesion, predominantly skin lesion, underlying skin lesion will be better side. There is three way of packing. It will be different form of packing. We did in our place also. There is first you need to take sample and put it there, and then you need to cover with plaster or something else, whatever you have, and then again you put it to the another some tube container, same like that tube like that, and then again you need to pack, and then again you need to put for thermocol, some box, if that one thermocol or something, which box you put it like that. This is the three way of packing. For example, there is the high chances of contamination. It will be prevented by this one. There is difference. Mainly we have in NIV Pune. This one form is there. The mainly few laboratories that will be collaborated with NIV Pune. If directly it will be difficult to send through your NIV, you need to send actual method. The investigation of choice will be, as per I told, PCR. It's not IgM or IgG. It will be PCR. Skin lesion will be better choice. This much you know. This question will come. Monkeypox is rising. Whether drugs will be worse or not. Same like COVID. Which one is will work or not? Either will go which all antiviral is there. Which drug it will be. Also you need to decide. The primary role of treatment is always isolation and quarantine. Same way the third will be repeated in COVID. Same thing again going to repeat it. Monkeypox, isolation will be predominantly. Always go with supportive treatment, like the skin rashes that you go treat the skin lesions, whatever you do dressing, proper dressing, you need to do. Other oral lesion or something is there, self-care will be important. Dehydration is also important for patient dehydration, same like viral illness. Other supportive management, if you at all want paracetamol or something, I use you need to give. Patient, you need to monitor, same thing, vitals, everything from CNS head to foot, you need to monitor CVS, RS, abdomen, everything you need to monitor. The chances of severity will be very high in immunocompromised patients. Immunocompromised, whoever is the HIV, transplant patients, even rheumatological patients, even malignancy patients, high dose of steroid patients, the chances will be high. The treatment will be either cidofovir or tecovirimat. Cidofovir, it will be asked by DNA polymerase. The drug will be better effect, but the side effect will be very severe with cidofovir. Suppose tecovirimat, it will work by P37 protein inhibitor. This one drug is also available in India. It's mainly approved in smallpox. These two drugs are available in India, both cidofovir and tecovirimat. Already I told. The monkeypox vaccinations available in world or India. This question will come again. Is a prevention aspect. We go ahead. There is two type of vaccines available in world. Either ACOM 2000 or Janus. That one is either recombinant or replication. Either replication competent vaccinia virus or replicant deficient modified Ankara vaccine, this one. Suppose you ask which one is better, ACOM 2000, it will be better choice. But the problem with ACOM, there is multiple puncture technique in single dose. This prophylaxis, there is no much role, but if at all you want exposure within 4 days, it will be effective. Some people are theoretically they're telling like smallpox vaccine will work, but again data we don't have. Smallpox will work or not. The clear data we don't have. Without clear data, I won't suggest smallpox vaccines. Suppose you want more idea of dates, contact me. Any interesting cases there, better discuss with me. We are also planning to conduct ID conference on January 4 and 5 in Madurai. If possible, more ID updates, please join. Again, thanks to IMA. Yes, sir.
Thank you, sir.
Thank you.
May I request Dr. Napoleon, sir, for his closing comments?
Good evening to all. Really, Dr. Santanam explained the basics about the monkeypox. Actually, those born before 1977 or 80, definitely they were not exposed to this history of smallpox at all. So it was a deadly one, and how it was completely eradicated, and still the vaccine virus is maintained in Russia and Georgia, Atlanta. So that was, now it is helped. Vaccine again from the same smallpox vaccine. Almost 58% of success rate is there. So once it was, we are not bothered about the disease. Now again it regained in the way of monkeypox. So you must be always aware of the emerging viral disease. So it was a very nice presentation by Dr. Santanam. Thank you. Thank you.
Thank you, sir. We'll move on to the next topic by Dr. Ram Subramaniam, sir. The topic is on organ donation current practice. The moderator will be moderator of this topic will be Dr. Abubakar, sir, Vice President of IAP Tirunelveli branch, who is a pediatric surgeon. And the expert comment will be from Dr. Raja Vignesh, sir, who is another Vice President of IAP Tirunelveli branch and senior neurosurgeon. Dr. Abubakar, sir. Okay, I think sir is not available, sir. Dr. Ram Subramaniam, sir, needs no introduction. He is our senior nephrologist, professor and HOD of Department of Nephrology in Tirunelveli Medical College. Over to you, sir.
So at the outset, I thank IMA for giving me this opportunity. My sincere apologies for all this delay. So my talk has been organ donation current perspective. So I will be, since I am concerned with the kidney transplant only, I will be sticking to the kidney issues only. But anyhow, the legal, that is the rules and all are same for all the organs. So in the next 15 minutes, I will be talking about the legalities and the especially the how the donor is that is the worked up, etc. So the first kidney transplant was done by Dr. Joseph Edward Murray. This history you all know. He was awarded a Nobel Prize for his work in 1990. Next slide. So India's first kidney transplant was done in CMC Vellore by Dr. Mohan Rao. Next slide. See, the in 2018, after a lot of problems, 2008, after a lot of problems with the kidney transplantation in Tamil Nadu, the Tamil Nadu government set up an authority called the Transplant Authority of Tamil Nadu, which is the guiding agency for all the transplant related activities, especially the cadaver transplant. Next slide. So this is the number of transplants done so far as per the registry of the transplant.
இல்ல லாஸ்ட் இது எனக்கு திருப்பி அது
Next slide.
போஸ்ட் நீங்க தான் வந்திருக்கு. இனிமே ஒண்ணும் இல்ல, ஆனா அது பண்ணிட்டேன்.
Next slide, please. Okay. So this is the waiting list. So what is the need for an organ transplant? That is to have all these rules and the other organ sharing networks, etc. Because the kidney disease is more prevalent, and as on today, 7,140 patients have been waiting for the kidneys, and 400 patients have been waiting for liver. Of course, lung and other organs are also being transplanted. Next slide. You all know CKD is a very major non-communicable disease. Almost 10% of the population suffer from kidney disease. 210,000 patients enter into the stage 5 for dialysis. But of course, on dialysis at any point of time, only less than 2 lakh patients are on dialysis. Most of the patients are in hemodialysis, and the funding is mainly by self-funding only. So the cost per dialysis session is so in a private setup is somewhere between 1,100 to 4,500. In a public hospital, to establish a setup for the dialysis, one dialysis session costs for roughly 4,000 rupees. Next slide. So the hemodialysis introduced in 1962, the PD, the CAPD, that is the continuous ambulatory peritoneal dialysis, 1991. But the problem is many of the patients live in unhygienic conditions and lack of separate clean room. So that is a major impediment for having the CAPD program. Numbers, that is a transplant. The problem is the then and there we get news of the commercial transplantation allegations, etc. So this is one problem concerning the transplantation. Next slide. The monthly expenditure per patient per rupees comes around 30,000 of all the that is out of pocket. Next slide. So what is the need for transplantation? See, various studies have found that patient on continuous dialysis, when compared with the patients undergoing a cadaver transplant or marginal transplant from of a kidney from a marginal donor, they have found that on long-term basis, the outcome, patient survival is better with transplantation rather than on dialysis. So we always try to convince the patients for transplantation when there is a possibility. Next slide. So in case of shall be solely on the authorization committee. So near related, immediate blood relation like parents, siblings, children, grandparents, grandchildren, and spouse. So that is why people used to tell, see, the committee is insisting on so many documents, etc. So this is to avoid any illegality in the transplant. Next slide. Next slide, please, sir. And the Tamil Nadu government, they have given clarification for the, they have made a gazette notification, especially for the spousal donation. Next slide. See, husband to wife, wife to husband, we call it as a spousal donation. Next slide, sir, please. You can see when the point number 2. Registered medical practitioner, that is in charge of the transplant center, must evaluate the fact and duration of the marriage and ensure the documents such as marriage certificate, marriage photograph, etc. So, but conventionally, though there is no time frame mentioned, conventionally we follow that the couple should have been married for at least 5 or 6 years, so that this marriage itself is not for a organ donation. Next slide. So now to facilitate the organ sharing between the various states, the Government of India under the Director General of Health Services, they have established various organizations called NOTO, that is National Organ and Tissue Transplant Organization, ROTO, Regional Organ and Tissue Transplant Organization, SOTO, State Organ and Tissue Transplant Organization. This is the regional centers are in Chennai, Mumbai, Kolkata, Chandigarh, Guwahati. This is to facilitate an organ, that is especially the cadaveric organ from the neighboring states, etc. Next slide. So now they have even department of organs, that is especially cadaveric organs to people waiting on in the. So they have given various criteria: duration of dialysis, the previous transplant with a graft failure, multiple dialysis access failure, etc. The last one they have added is the near relative of a previous deceased donor. Suppose if somebody has given a donation, some family has given a donation, that is after that is a cadaveric donation after death of a relative, the person's relative who is requiring a kidney transplant can be given preference. There's 5 points are given for that. So periodically this the allocation criteria are being altered to facilitate the organ, the best use of the organs. Next slide. So the regional centers, the Tamil Nadu center is in the multi-speciality hospital, Omandura Hospital. It covers TN, Kerala, Telangana, Andhra, Karnataka, Pondicherry, Andaman Nicobar, and Lakshadweep. So this is the regional setups. Next slide. Kidney retrieved from a government hospital will be allocated as follows. The first patients listed in the government hospital only, government only hospitals, then combined government and private, then patient listed in the private only. So for a private hospital, the first that hospital, if the organ is a paired one, that hospital will have a priority for one organ, that is a kidney, and the second organ will go to the combined government and private hospital pool. Next slide. So very strict punishment has been given. So as per section, any person who is responsible for the removal of a human organ or a tissue without the authority of doing so can be punished with imprisonment, which can extend up to 10 years, and with a fine which can extend up to 20 lakhs. As per 19, if any person involves himself or herself in the commercial dealing of the human organ, then such person can be punished with imprisonment for a term not less than 5 years, but can extend to 10 years with a fine from 20 lakhs. As per section 20, any person violating any other provision provisions are made to prevent the illegal sale of human organs. Next slide. So living organ donation, that is normally the kidney is the one which is being transplanted regularly. Of course, liver also can be given living donor. Types of living donor, we have the ear-related, non-ear-related, and swab donors. Suppose if if a patient has got a donor, a relative donor who is not blood group compatible, if another pair of donor recipient are there, if there is a match between the other donor with this patient, then they can swap this transplant. Of course, it is a very difficult. Both the surgeries should happen simultaneously. Larger institutions like CMC Vellore are doing this swap-like transplantation. Next slide. Then the disease donor organ donation. As you all know, the brain death. See, the government has given a GO which defines the brain death and how to certify the brain death also. So, what is called as cadaveric donor, we call it as a disease donor organ donation. That is donation after brain death. Death after, that is cardiopulmonary criteria, is called cardiac death. But of course, out of supports, it becomes a cardiac death, post cardiac death donation. Next slide. So brain death, they have given criteria. Other causes of reversible causes to be excluded. One apnea test is supposed to be the most important one. How to perform the apnea test and all have been given in the GO itself. So normally, when a brain death donor is identified, the coordinator who is a should not be a urologist, should not be a nephrologist. A person who is not interested, who has got no interest, should be the coordinator, and he has to talk to the family. And if the family is willing, they will be doing the apnea test. Apnea test to be done at the interval of 6 hours by 2 separate teams. And if the brain death is confirmed twice, then the Transtan in Tamil Nadu is informed, and they alert the expanded criteria donors also. You see, that is to prevent wastage of organs. They have even suppose aged 50 to 59 with hypertension or pre-retrieval, that is marginal donors. They have given some extended, because studies have found out that these kidneys also can work for a few years for a patient who is on dialysis, whose life, that is the period of life is very less compared to the life after transplant. Next slide. So there is a donation after cardiac death also in the other countries. Next slide. Then ABO compatible versus ABO incompatible donation. With reference to the kidneys, see, the main criteria is blood group compatibility. Of course, the incompatible transplant also is in the rise in our country, because we have various techniques like plasmapheresis, etc., to remove the antibodies which are present in the circulation. See, O is a universal donor like a blood group, and AB is a universal recipient. So the other groups, they can have this that is ABO incompatible. Of course, a bit costly, because you have to give plasmapheresis multiple times, and you need to give IVIG, etc. So of course, though it's costly, if the near relative is very much motivated and blood group compatibility is not there, the patients can try a ABO incompatible transplant. Next slide. So this is the recipient and donor blood groups. Next slide. Xenotransplantation, you all know, recently there was a successful xenotransplantation from a pig to that is a human being, which was working well, but unfortunately the patient died after a month with a working graft due to some other, that is infection and all, but the graft was functioning. So this has opened a new that is area of cultivating the that is the animal that is organs for from the animals to the human beings. Next slide. So absolute contraindication for transplant is uncontrolled malignancy, active HIV infection, and life expectancy less than 2 years due to other illness. That is why before the patient undergoes a transplant, especially if diabetic and more than 40 years old, and if he has got features of cardiac that is cardiac symptoms, we always insist on a coronary angio to rule out coronary artery disease, etc. Otherwise, the other contraindications are a relative one only. Next slide. I thank the IMA for giving me this opportunity to talk for a few minutes about the current perspective of organ donation. The one thing is, we have a live donation which has to be between the near relatives. If the if the donor is a not near relative, the approval rests with the authorization committee. It has to convince itself that the donation is genuine. For cadaver, the patients can register themselves for in any of the hospitals, and they will get a number, waiting list number, and based on the this one, the transplant will allot the organs. So thank you very much. Thank you for your patient listening, and I apologize once again for all the disturbances during my presentation. Thank you.
Thank you, sir. Thank you, sir. Raja sir, to give his closing comments, sir. Sorry, sir.
Thank you, Prabhu. So Ram Subramanian sir explained in brief about the current trend and guidelines for transplant, and more or less what applies to kidney applies to all organs as well. So in this note, I wish to add a few tidbits, because we neurosurgeons are concerned with certifying brain deaths. So especially in Tamil Nadu, we do a lot of work in brain death. So two important things which are being done exclusively in Tamil Nadu is, all government medical colleges or hospitals are non-transplant retrieval center. So this is one of the greatest thing that is being done by transplant, because previously, even for retrieval of the organs, you have to transport the patient in difficult circumstances to nearby medical colleges or any center. Nowadays, the transplant team, the retrieval team can themselves come to these medical colleges and pick up the organ. One. And few other things is, one, when after we certify brain death, just before certifying brain death, potential brain death patients can be identified, and we can inform the counselors. Counselors are totally unrelated to us, to the hospital, and they will come and talk to the relatives, and if they are willing, we go for apnea test. Previously it was apnea test, then talking to relatives. Nowadays it is only when the attenders or relatives give consent, you have to go for apnea test. Then one another thing that has been brought by Government of India and is being followed in Tamil Nadu is, even other district smaller hospitals, if you have some brain death, you can have treating physicians, MD or MS or even RMO can be part of the team that can certify brain death. And one thing which we must remember is, there will be 4 signatures. Among them, 2 things are very important: treating doctor and certifying doctor. So the certifying doctor and treating doctor should not be the same. For example, if it is a head injury, myself being a neurosurgeon will be the treating doctor. Hence, I will sign in treating doctor's column. And the other one, probably neurologists in medical colleges or some other physician will sign in the person who declares and certifies the brain death. If it is a brainstem stroke or a cerebrovascular accident, the neurologist will sign in treating doctor column, and the neurosurgeon or somebody else will sign in the certifying doctor's column. This is because to avoid some malpractices wherein the treating doctor may be involved in trafficking or racket. So with this, I conclude my comments. So thanks for the opportunity. It was a wonderful event. Thank you.
Thank you, sir. Over to Dr. Ibrahim, sir.
Good evening, sir. So it was an exhaustive, wonderful session of various topics from various departments, starting from vaccination and practice of type 2 diabetes mellitus, approach to chest pain, PPI abuse, stress busters for doctors, polypharmacy on the rise, subfertility, and monkeypox, and finally, organ transplantation. So these are wonderful talks on various topics. I think only some of the audiences would have been able to listen all the 9 topics, I guess. So from various departments, we had the doyens of practicing doctors from various branches of South Zone. So wonderful presentation. I thank the state office bearers and also the AMS office bearers for giving IMA Tirunelveli this golden opportunity for conducting this online CME on AMS. And at this outset, I congratulate and thank Dr. Prabharaj for single-handedly organizing these events, talking to various speakers, moderators, and chairpersons, as I was out of country for nearly 2 weeks for a robotic surgery training in US. So he single-handedly did everything, and along with our branch president, Dr. Subramaniam sir. So I congratulate and thank all the speakers, chairpersons, and audience for the wonderful CME by AMS. Thank you, sir.
Thank you, one and all, sir. Thank you.
So I request our branch finance secretary, Dr. Prabharaj sir, to give the formal vote of thanks and close the ceremony.
Thank you, sir. We thank all the office bearers of AMS and IMA State Branch. Special thanks to the speakers, moderators, and expertise of all the topic. I also thank all the members who have participated in this Zoom meeting today. Thank you, sir. Thank you.
Thank you. Thank you, everyone.
Thank you all, sir. Thank you. Thank you, Rajesh Babu, sir. Thank you, sir.
Welcome, sir. Welcome.
Thank you, sir.
Thank you, sir.